Right. Good morning. So we'll start without wasting the time. So I have shared the paper. So actually, I'm really sorry. So I could connect the class through the phone because my I'm having some problem with my MacBook. Something is not opening. So we'll start with the paper first. So then later we'll sort out this problem. So I have shared the paper, so you might have the paper. So can you all hear me? Yes. Can you all hear me? Yes. Okay. Fine. Right. That's fine. Okay. Thank you. So we'll start with the paper first. Question number 1 in miscarriage, right? So I think, yeah, good morning. So I think you might have the paper. So first we'll start with the MCQ, the miscarriage. Uterine size is less than the period of amenorrhea. So obviously that is true because we know if it is a miscarriage, then the live baby, it's going to be smaller than the life healthy pregnancy. So the uterine size is less than the period of amenorrhea. Yes, that is true. So coagulopathy is a recognized complication. Actually, in miscarriage, the coagulopathy is less likely, right? So until the miscarriage causing heavy bleeding, severe bleeding, causing severe bleeding, causing DIC, it's possible. Otherwise, in miscarriage, the risk of coagulopathy is very less. The development of DIC is very less in miscarriage. So what do you understand by miscarriage? Miscarriage is there is a miscarriage. The pregnancy has lost. It's unviable pregnancy. Pregnancy might last. So that is called miscarriage. So in miscarriage, coagulopathy is a recognized complication. That is wrong. That is false, right? So if it is an abruption or heavy bleeding, yeah, that is a recognized complication, not the miscarriage, right? The patient commonly present with hyperemesis gravidarum. So what do you think about this treatment? That is obviously it's false because we know in pregnant women that why they are having vomiting because of the HCG. So in miscarriage, actually the pregnancy is not healthy. Its pregnancy is going to lose. So in that case, right? So in that case, so the unhealthy pregnancy will produce less amount of HCG. So if it is less amount of HCG, the risk of vomiting also it's going to be less, right? So that's why. So this the commonly present with hyperemesis gravidarum, it's going to be false because less is HCG, so less number of less chance to develop the vomiting. Viral infection is a causative factor, right? It's like that. So if you have normal viral infection like pharyngitis, coronavirus, like some kind of normal viral infection, it won't cause miscarriage, but right. So some viral infection can cause fetal anomaly like rubella, right? So the rubella viral infection can cause fetal anomaly, which can cause miscarriage. So pregnancy might last because of the fetal anomaly, right? So viral infection is a causative factor. That is the word is problematic. Viral infection can be a causative factor. That is true, right? Because you know why? Because if somebody develop rubella infection, yes, right? Viral infection is a causative factor. So it means all the viral infection will not cause miscarriage. So that's why we have to take it as false, because it's not a all the viral infection, it's not a causative factor. So viral infection can be a causative factor. So that's a word you should be very careful when we use the wording in MCQs. And cervical cerclage is recommended in subsequent pregnancy. What do you think? So why we are offering the cervical cerclage? So what is cerclage? So we are putting the stitch around the cervix to strengthen the cervix. If somebody has cervical incompetency, right, when the cervix is not that much of a strength enough, right, strength enough, what we do is we are just strengthening the cervix with a stitch, right? So if somebody has second trimester miscarriage due to cervical incompetency in previous pregnancy, so next pregnancy, what we used to do is we assess the cervical length with the transvaginal ultrasound scan. If the cervical length is less than 25 millimeter, it's indicating the cervical incompetency. They might need cervical cerclage. So in cervical cerclage, in cervical incompetency, there is no problem in the pregnancy. Pregnancy will lose because of the cervical incompetency. The baby will be all right. So the active baby, healthy baby, but baby lost, the pregnancy loss due to cervical incompetency. So in that case, of course, we need to offer the cervical cerclage. But here it's a miscarriage. It's not a problem with the it's not a problem with the cervix. Actually, the problem is with the pregnancy. The baby is not healthy, right? So for the unhealthy baby causing miscarriage, no point in putting the cerclage. So that is false. So the answers are true, false, 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 true. So you might have confusion in stem D. Viral infection is a causative factor. That is the, yeah, good morning, Lasandar. That is the problematic things here, because viral infection can be a causative factor, right? So viral infection is a causative factor because all the viral infection will not cause this miscarriage, right? Fine. So second question regarding the operative delivery. So operative delivery in the sense either vaginal delivery, so the instrument forceps delivery or vacuum delivery. Kephal hematoma is a complication of vacuum delivery. Yes, that's true, because when you are putting the forceps over the skull, right? So it might cause any kind of infection, bleeding into the brain, like Kephal hematoma, subgaleal hematoma, intracranial hematoma, right? So hemorrhage. So most of the hemorrhage will occur with the vacuum delivery, especially if it is a preterm delivery, right? So preterm, it's very high risk for the bleeding. So that's why, so vacuum delivery we are not offering, or we are not recommending for less than 34 weeks, as it is causing intracranial hemorrhage, right? So Kephal hematoma is a complication of vacuum delivery. Yes, that's true. Forceps used in obstructed labor, that is false. If it is an obstructed labor, it means the passage is not adequate to allow the passenger. So in that case, you can't deliver the baby through the vagina. That's the problem. So you can't deliver, whether you are pulling with your heart effect, or whether you are very powerful man, whether you are pulling. So either if you pull the baby through the inadequate space, definitely baby will develop trauma, as well as the mother will develop trauma. So the obstructed labor is a contraindication for vaginal delivery. So then no point in putting the, you can't put the forceps delivery, forceps or vacuum. Instruments can't be used, right? If the space is adequate, if the passage is allowing the passenger to come out, yes, you can put the forceps and deliver the baby. Here you can't do, right? So forceps used in obstructed labor, that is false, we can't, right? So there are features to diagnose the obstructed labor, like lack of progression, fetal distress, hematuria, right? Severe molding, severe caput, right? Cervical edema. So these are the features. So if it is a lack of progression or prolonged second stage, when you do the vaginal examination, if you find these kind of findings, so it's suggestive of obstructed labor, then you can't do the instrumental delivery. You have to go for a cesarean section, right? So obstructed labor, forceps delivery, forceps used in obstructed labor, that is false. Key-line forceps is used to deliver the occipital posterior position. The key-line forceps is rotational forceps, right? So the rotational forceps we are using to deliver the occipitotransverse babies, right? So occipitotransverse, actually I'm really sorry today I couldn't draw the diagram because I don't know why. So I couldn't connect through the computer. So then I am just coming through the phone. So that's why I couldn't draw a diagram. So I'm really sorry. So I'll try to explain without diagram, so you just try to understand. So I'll sort it out quickly. I don't know. It's not working. Okay, fine. Right, fine, it's okay. Right, so the keel and forceps is used to deliver the occipital posterior position. Actually, that is false. It's used to deliver the occipital transverse position, right? So if it is occipital posterior, you can deliver with a normal forceps. But if it is occipital transverse, we need to turn the baby to occipital anterior, occipital posterior. Then only we can deliver the baby, right? So in that case, we need to rotate the baby to occipital or anterior, occipital posterior, right? So for that, what we have to do is we have to rotate it. So the rotation can be done manually or with the help of forceps, with the rotational forceps, or we can do with the vacuum delivery, right? So the keel and forceps is used to deliver the occipital posterior position. That is false. That is used to deliver the occipital transverse, right? The forceps delivery is contraindicated in phase presentation. That is false. If it is a phase presentation, what you can do, you can put the forceps either side of the baby and pull and deliver the baby, right? Like this. You put it and deliver. But for the phase presentation, now the face is in the vagina, then you can't put the vacuum and deliver the baby, because once you apply the negative pressure over the face, right, over the face, there will be a fetal face damage. So that's why you can't deliver the baby with a vacuum. So the vacuum is not recommended for the face presentation, but forceps is recommended, right? Forceps is recommended. So forceps delivery is contraindicated in face presentation. That is false. Bucket handle tear of the cervix is a complication of vacuum delivery. Yeah, that is true. Because when you put the vacuum, there is a high chance of having a posterior lip of the cervical tear. So that is called bucket handle tear. So that is true. So the answers for question number 2, true, false, 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 true, right. Question number 3, external cephalic version should be performed under general anesthesia. So external cephalic version, turning the baby to the cephalic presentation from breech presentation to make sure the baby to deliver vaginally, cephalic presentation, right? So then what we used to do is, right, what we used to do is, we are turning the baby in the ward setup. You don't need to give this general anesthesia or spinal anesthesia. We are just giving some pain relief while we are turning the baby. Mother might have pain. That's why we are giving the pain relief. Maybe like pethidine, like that, right? So should be performed under general anesthesia. That is false. Is outpatient procedure or maybe an inward procedure. Not even in the theater. It's in the ward. Does not affect the incidence of breech delivery. That is false, right? The purpose of turning the baby, right, to cephalic presentation to make sure the baby is delivering by the head, right? So the success rate of the breech is around 50%, right? So it means if you try to turn the baby to cephalic presentation, around 50% of the breech is going to have the vaginal delivery. So it's reducing the breech delivery percentage. So if the stem came as ECV affect the incidence of breech presentation? True or false? What do you think? ECV affect the incidence of breech presentation. What do you think? That is false, because breech presentation will not change. Here they ask breech delivery, because breech presentation is due to some other reason, like so the placenta previa, uterine anomaly, right? So lower uterine segment, fibroid, and like this. So in that case, of course, the presentation might affect due to the breech presentation might affect due to some other cause, not due to ECV. But here they are asking about breech delivery. So how many breech is going to deliver vaginally? So once you turn it, obviously the percentage of breech delivery is going to be less, right? There are so many chat I didn't see. Okay, it's going to be difficult for me. The students who are having exam, you have to come a bit early to the class. Right. Okay. So does not affect the incidence of breech delivery. That is false. It will affect the incidence of breech delivery. Right. Carries a risk of uterine rupture. ECV carries a risk of uterine rupture. That is true, because once you turn the baby, the uterus might get rupture. It's a very rare complication, but it has a risk of uterine rupture. It's successful in over 90% of attempt. No, I told you the attempt, the successfulness is around 50%, but successfulness will vary depend on the factors, like if you are doing in a later POA, the breech might engage less, like also then successfulness will be reduced. So if you do for the primary around 36 and multi around 37 week, the successfulness will be high. So the successfulness over 90% of the attempt, that is false. Should not be attempt in rhesus negative woman. Should not be attempt in rhesus negative woman. That is false. We can, but we may have to give the ROGUM. That is false. So the answer false, false, true, false, false. Question number 4, regarding contraindication for trial of vaginal birth after cesarean section. So what are the contraindications for trial of cesarean section after trial of vaginal birth? So after cesarean section, we are trying to go for a vaginal delivery, right? So what are the contraindications? Lower uterine tear in the past. So if you have a uterine tear, right, the risk of rupture will be high when compared to lower segment cesarean section. So usually your lower uterine tear is a relative contraindication. But if it is a previous uterine rupture, the risk of uterine rupture in consequent pregnancy is around 5%. So that's usually contraindication, right? So if it is a classical uterine incision, so classical means there are two types of incision. One is transverse lower segment, that is called lower segment cesarean section. Another one is we are cutting vertically, that is called classical incision. So when you cut classically, you are cutting most of the muscle fibers, then rupture risk is high. So then for the classical uterine cesarean section, we don't go for vaginal delivery. That is always cesarean section, because the risk of uterine rupture is going to be very high, right? So but the transverse cesarean section, you can go for vaginal delivery. It's not a big thing, right? But there is a small risk when compared to normal vaginal delivery, previous normal vaginal delivery, small risk of uterine rupture. What is the risk of uterine rupture in lower segment cesarean section? Is 1 in 200. It means 0.5%. Around 0.5% of mothers will develop uterine rupture in consequent pregnancy for a lower segment cesarean section. But if it is upper segment cesarean section or uterine rupture or uterine tear, is slightly higher risk of rupture rate, right? So that's why it's a lower uterine tear in past is a relative contraindication. J-shape incision on the uterus. Again, what is J-shape incision in the uterus? So what we used to do is we are cutting this uterus in the lower part like this, transversely, like this. So, but if we don't have a space, then what we used to do is to increase the space in the corner, one corner, we are extending the incision like this. Now you can see, this is called J-shape incision. So in J-shape incision, in the corner, we are extending the incision upward. Once you extend the incision upward, what will happen? The muscle fiber rupture, the damage is high and uterine rupture risk is, when compared to lower segment cesarean section, it's a bit high. So that's why the J-shape incision or T-shape incision, why we are putting this J-shape and T-shape, to increase the size of the entrance, right? So if you just cut in the lower part, this is the entrance only. So if you want to extend, then we are extending in the center part or corner part. If you extend as a center part, so then it's like T-shape. If you extend in a corner part, that is like a J shape, right? Okay. So the T incision, J incisions are relative contraindication, not an absolute contraindication. Breech presentation, pass Tralowska breech presentation. Yes, that is a contraindication, because for the breech delivery, right, we may have to do some maneuvers. We may have to put the hands inside and pull the baby. So then while you are doing the maneuver to deliver the baby, there is a risk of uterine rupture. That's why the breech presentation is a contraindication too. Head not engaged at term. So head not engaged at term is not a contraindication, but the successfulness of the Rylowska might be less. The thing is, because if it is a multi, usually the head will engage at with the onset of labor. Usually it's like that for the multi. For the primary, the head engagement might be a bit early, right? So another cause for the head knot engagement, the space might not be inadequate, like cephalopelvic disproportion. So in that case, your breech delivery, your vaginal birth after cesarean section might not be possible, right? But if it is a multi, once the labor starts, then head might engage and labor might progress. So you can't say if the head is not engaged, it's contraindication. So it's a less successful factor. You may have to consider about the cesarean section. It's not a contraindication. That is false. Pre-labor rupture of membrane, right? So if the membrane got ruptured, it's not a contraindication for Rylowska. So sometime after rupture of labor membrane, the labor might progress. So that is false. So the answers are true, 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 false, false. Of course, I'm doing a bit fast because now this is the time to do the paper only, because already we have spent a lot of time. We explain a lot. We studied a lot. Now you people are very good in the knowledge. Now we are just doing some papers or some questions. These questions are going to appear in your exams, right? So definitely will appear. So you need to have some more experience, and also you have to understand the concept of these questions, right? So then you can apply and you can get through the exam. So soon I will give another feedback from my one of the batch, the KDU. So I have done a class for the KDU students. So quite a number of students came for the classes, so not for the MCQ, SCQ, as well as the long case. So tomorrow they are going to have the exam results. So then I'll tell you the success rates. So then you will realize which method of teaching is good to get through the exams, right? So I'll tell you the next class how is the success rate, because tomorrow will be the results, right? Fine. So the question number 4, answers are true, 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 false, false, right? Question number 5, regarding anesthesia for lower segment cesarean section. Epidural anesthesia is causing hypotension. Of course, it can cause hypotension. Epidural and spinal, when you are giving the anesthesia, it causes the peripheral vasodilatation, which causes hypotension. Yeah, that's possible. But when compared to epidural, spinal anesthesia has high risk of developing hypotension when compared to epidural, right? But epidural also can cause hypotension, but the spinal is more risk to develop hypotension. Neonatal respiratory depression occur with general anesthesia. What do you think? Yes, neonatal respiratory depression can occur with general anesthesia. What do you think? What do you think? Yes, true or false? Yeah, that's true, because the General anesthetic agent cause muscle relaxant effect. So which can cause muscle relaxant and cause respiratory depression to the baby. Yeah, that's true. Spinal anesthesia does not need continuous cardiovascular monitoring. That is false, because as I told you, spinal anesthesia can cause hypotension, so which need continuous cardiac monitoring. Spinal anesthesia has greater risk of aspiration. That is false, because spinal anesthesia we are blocking at the level of L2, L3, right? So actually we are giving at L3 level, right? So but the anesthetic block go up to T10 level, T10 to T8, T10 level. So that is our target, T10 level. So below T10 level, but the laryngeal reflexes are cervical nerve roots, very high. So as we are blocking at the thoracic nerve level, your laryngeal reflexes are intact. So that will prevent the aspiration. But in spinal anesthesia, general anesthesia, we are relaxing all muscles. So your pharyngeal reflexes will go soft. So then patient has high risk of aspiration. So general anesthesia has high risk of aspiration than spinal. That's why we are giving the spinal anesthesia. Spinal anesthesia has greater risk of aspiration. That is false. 12 hours fasting is required for the spinal anesthesia. That is false. So for the solid food, 6 hours is enough. You don't need to have the 12 hours. 6 hours is enough for solid food. For the clear fluid, it's 2 hours, right? Solid food 6 hours, clear fluid 2 hours. So the answers are true, true, false, false, false. Question number 6. Indication for ring pessary. So the ring pessary we are inserting into the vagina to hold the cervix in an upper position, right? So it's kind of supportive pessary, right? Supportive pessary. There are two types of pessary. One is supportive pessary. Second one is obliterative, space occupying pessaries, right? So the shelf pessary is space occupying pessary. So we are obliterating the vaginal cavity so that nothing will come out. Here in ring pessary, we are holding the uterus bit higher up, which will hold the uterus in a higher up position, so it will not come out. So what are the indications for the ring pessary? Urge incontinence due to detrusor instability. So detrusor instability is something problem with the detrusor muscle, so the pessary will not help for that. So that is false. Enterocele, so the enterocele is problem with the pouch of Douglas, so that will not give the support to the pouch of Douglas. That is false. UV prolapse in pregnancy, that is true, because if somebody has UV prolapse, maybe in the early pregnancy, uterus might be in the lower down. With enlarged baby, right? So when the baby is growing, enlarged uterus will goes up to the cervicasternum, right? Up to the cervicasternum. Once the baby enlarges, the uterus will goes up because the pelvis is not adequate. So the uterus will goes up. So maybe until the period of gestation increase, right? Until the period of gestation increase, she might need some kind of temporary measures. So in pregnancy, what we used to do is pregnancy, we are putting the ring pessary for a short period until the uterus enlarge. So that is true. UV prolapse is decubitus ulcers, but not in ring ulcers, right? So what is decubitus ulcers? We know when the uterus is hanging outside, right? It's hang on the vascular pedicle, so the veins are getting stretched and the blood is going to accumulate in the uterus like a varicose vein. So when the blood is accumulating in the uterus, it can cause decubitus ulcers, right? So if it is a decubitus ulcers with the inflammation and edematous uterus, you can't cut and you can't take the uterus out. So the vaginal hysterectomy is not possible with the decubitus ulcers and the edema. So in that case, what you have to do is you have to replace the uterus to the normal position, right? So then, so the stretching of the vessels will release and blood will go back. Then ulcer will heal. After that, you can do the vaginal hysterectomy. So for the temporary measures to relieve the vessels stretching, we may have to replace the uterus to the normal position. So for that, we may have to put the ring pessary. So the decubitus ulcers, that is true. Hypertrophic elongation of the cervix. What do you understand by hypertrophic elongation of the cervix? In UV prolapse, uterus is coming down. In hypertrophic elongation of cervix, the cervix is elongated. Cervix is elongated. Cervix only it's coming out. So in that case, you can't push the cervix up. So then the ring pessary doesn't have any role in the hypertrophic elongated cervix. Only you can do is, only what you can do is, you can cut the cervix and take it off. Okay, so that is false. So then somebody asked, what is ring ulcers? Yes, anybody? What is ring ulcers? What is ring ulcers? Yes, anybody? What is ring ulcers? What is ring ulcers? The ring ulcers is when you put the ring pessary because of the pessary. So just imagine. So this is your uterus. You put the ring like this, right? So this ring pessary is always having contact with the uterus, and it's eroding the uterus and the vagina and causing ulcers due to chronic irritation. That is called ring ulcers, right? So in that case, what is the management? You need to remove the ring pessary. That is one of the complications of ring pessary, ring ulcers, right? So the answers for question number 6, false, false, true, true, false. Right. Next question, question number 7. Complication of diagnostic laparoscopy, right? So you are putting the camera inside and you are just having a look of the peritoneal cavity, what is inside, right? So that is called diagnostic laparoscopy. Surgical emphysema. What do you understand by surgical emphysema? So in laparoscopy, we are creating the pneumoperitoneum. So we are inserting the CO2 into the peritoneal cavity. So then abdominal cavity will distend. So then you can put the camera and you can easily see the structures. That is called pneumoperitoneum. So we are creating the pneumoperitoneum with CO2, right? So sometime when you make an incision through the abdominal wall, or sometime when you are infiltrating the CO2 through the port, right? So that CO2 might enter into the tissue plane, like a peritoneum. So the visceral peritoneum, or maybe into the subcutaneous tissue, or maybe into the rectus sheath. So the gas might enter into the tissue plane. So if the gas enter into the tissue plane, that is called emphysema, right? That is called surgical emphysema. So the surgical emphysema is possible in laparoscopic surgeries. That is true. Damage to the inferior epigastric arteries, yes, that is true, because we know. So the inferior epigastric artery is coming from the lower part towards the upper, right? So when you are putting the probe, you might damage the inferior epigastric artery. That is true. Bladder perforation, yeah, that's possible, because when you put the trocar, when you put the needle into the abdominal cavity. So first what we do is, in laparoscopy, this is your abdominal cavity. So we are just making an incision and put a trocar. That is, trocar is the primary trocar and secondary trocar. So we are putting the primary trocar. So once you put it, then there will be a hole. Through the hole, you can put the camera. So always the first trocar we are putting blindly. We don't see what is inside. We are just putting, then only we are putting the camera and we can see the interior of the abdominal cavity. Then you can put the secondary trocar. So the secondary trocars, so the other ports are we are seeing on the visual, but the first primary trocar we are putting blindly. So when you put blind trocar, right, so there might be adhesions inside, bladder inside, bowel inside, right? So if it is abdominal cavity, what is the deepest dangerous structure? Anyone? If you prick something into the abdominal cavity, what are the structures you might damage? One, you can damage bladder. Another one, you can damage bowel. What else you can damage? Aorta, very good. Aorta, because the aorta is in the posterior side. So you might damage the aorta. So the blood vessel damage. So those are the complications of laparoscopic surgery, right? So damage to the bladder, yeah, bladder perforation risk is high there, true. Pelvic adhesion, actually the laparoscopic surgery has less risk of pelvic adhesions. We don't think much about the pelvic adhesion with laparoscopic surgery. So pelvic adhesions, it's not a complication, that is false. Damage to the femoral nerve, actually the femoral nerve is into the posterior wall of the abdominal cavity, usually less chance to have the femoral nerve damage with a laparoscopic surgery, right? So that is false. So the answers for question number 7, true, 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 false, false, right? Episiotomy. So what is episiotomy? Episiotomy is a debilitated incision in the perineum to increase the vaginal opening to facilitate the fetal head delivery or breech delivery, whatever. Right? So it's a debilitated incision in the vaginal perineum or vaginal opening to increase the size of the vaginal opening to facilitate the delivery. Right? So usually it's not recommended for all pregnancies, but if the perineum is smaller or if the perineum has a previous history of surgery, or if you are going to do some maneuvers or additional things into the perineum in addition to the fetal head, if you want to put your hands to do some maneuver like shoulder dystocia, breech delivery, in that case, you need to increase the size of the vaginal opening. So then you may have to put the incision to widen the opening, right? So the question is regarding episiotomy, allow widening of the vulval outlet. Yeah, obviously true. Given mediolaterally, yeah, that is two type of episiotomy. One is median episiotomy or mediolateral episiotomy. So if you put the median episiotomy, we know, so in the central part, your vagina, below its anal canal. So if you cut median, so straight away it will enter into the anal canal and anal damage is high. So if you put the mediolateral, so then anal damage is less. That's why the mediolateral episiotomy is recommended than the median one. Earlier, yes, median episiotomy also we have done. Now, usually we don't do median episiotomy. We are doing the mediolateral episiotomy. So, given mediolaterally, yeah, that's true. Can damage to the anal sphincter when given midline, I told you. Because the center part, we are having the vagina, below that anal canal. So if you cut medial part, so it straight away enter into the anal canal. So the risk of anal damage is there. Sutures with nylon. What do you think? True or false? Sutures, Sugandhika, sutures with nylon? Yeah, that's false. Because so it should be a absorbable suture material, right? So that is called Weigel. So we usually use the Weigel for the episiotomy repair. So the sutures with Weigel, not the nylon. Uses in shoulder dystocia, yeah, that's true. We are using in shoulder dystocia, that's true. Right, so the answers are true, 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 false, true. So please, so I have select these questions. So this question will appear in your exam. So please do again and again, repetition. And I'm always against for one thing. So even though I'm telling, yes, this question will come, I'm not promoting the students to memorize, because if you get some kind of alteration in the question, so if you try to memorize, then you will get more wrong answers. So then, so you might know, even though your seniors are telling memorize the answer, you can pass the exam, you have to think rationally as you are a obs-gyne student. So if you can memorize, then why up to last year the pass rate for Genanops is 30%? Why they couldn't increase the pass rate to beyond that? Because memorization is not possible. So among that 30%, last 3 years I had a 80% pass rate among my students, right? So because Charita don't mark 80 to 90% of stems. So the last class I will give 30 minutes lectures after the paper, how to mark the paper. That one I will do it in the last class. How many stems you need to mark, how to do the exam, right? So those are the techniques. So you have to think in a rational way. So last 3 years I am doing the classes. So around 80% of my students get through the exams, but students who try to memorize the stuff, only 30% are passing. So always seniors might tell something. You have to inquire from your failed seniors. So the success seniors might tell some other different story, but failed seniors only know what are the problems they encountered in the exams, right? So yes, you will realize it after the exam. So most of the students are having the same scenario. They realize it after the exam. No point, no. Then you are losing another 6 months. So don't do that. Right, fine. So episiotomy answers are true, 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 false, true. Right. Question number 9. Third degree perineal tear during delivery. So the perineal tear, first degree is involvement of vaginal mucosa. Second degree, involvement of perineal muscles. Third degree, involvement of external anal sphincter and the internal anal sphincter. Fourth degree, involvement of anal mucosa. So the third degree, the anal sphincter complex involvement can be further divided into 3A, 3B, 3C. What do you understand by 3A? 3A means 50% of external anal sphincter involvement. 3B, more than 50% of external anal sphincter involvement. 3C, involvement of internal anal sphincter involvement, right? This is how we are classifying the anal sphincter damage or the perineal tear damage. So here the question is third degree perineal tear. So the third degree means involvement of your anal sphincter, right? So the involvement of rectal mucosa, that is false. That is fourth degree. Repair with non-absorbable suture material, again it's false. So this anal mucosa and things, anal muscles are repaired with the absorbable suture materials, right? So we are using the slow absorbable suture material, right? That is PDS, right? That is PDS. Repair under GA or spinal anesthesia, yeah, that's true. Because you can't do, if it is an anal sphincter damage, you can't do it in the labor room. You have to take the patient into the theater, and repair should be done in the GA or spinal anesthesia, right? That is true. Manage with post-operative laxative, that is true, because after the anal sphincter damage, patient should not strain for defecation, so you have to give the laxative for a few days, right? So if you are a house officer after the anal sphincter damage, always you have to give lactulose, right? So post-operative laxative, true. Can cause dysmenorrhea, yes. Sorry, dysmenorrhea false. It can cause dyspareunia, right? So dyspareunia can cause dyspareunia, not the dysmenorrhea, right? That is false. So answers for question number 9, false, false, true, true, false. Right. Question number 10, features of abnormal CTG in early labor. In early labor, features of abnormal CTG. Baseline heart rate is 150. What do you think? Baseline heart rate is 150. Abnormal, that is false, because the normal baseline heart rate in between 110 to 160. If it is 150, it's normal. Variability of 10, yeah, that is not abnormal, that is false, because the normal variability should be between 5 to 25. It's 10, so it's normal. 2 acceleration in 20 minutes, it's not a abnormal feature, right? So even absence of acceleration, it's not an abnormal feature, right? So that is false. Deceleration at the end of uterine contraction, it means they are asking about the late deceleration. So the late deceleration is an abnormal feature, but the late deceleration should last for more than 30 minutes. That is the criteria to say it's abnormal feature, right? So deceleration at the end of uterine contraction, that is true. Sinusoidal pattern, we know what is sinusoidal pattern. It's a symmetrical sawtooth appearance with a 15 beats per minute. It's like that. That is called sinusoidal. That is always abnormal. That may be due to hypoxia or fetal anemia. Any condition which causes fetal anemia, like a ruptured vasoprevia, right? Parvoviral infection, right? Or maybe a twin transfusion syndrome, or maybe a RH incompatibility, which causes fetal anemia, causing a sinusoidal pattern. So the sinusoidal pattern more than 10 minutes, it's a abnormal feature, right? So I think I have given a chart to you in the in the theory class, what are the abnormal features, what are the normal features. So then you can go through it, or it's in my book. Or so after the class, I will send the answer script as well, right? So as the students request not to send the answers, answer script. So okay, fine. Features of abnormal CTG in labor. So the acceleration in 20 minutes, that is not an abnormal feature, false. Deceleration at the end of uterine contraction, that is late deceleration, that is true. Sinusoidal pattern, yeah, that is more than 10 minutes, it's true. So the answers for question number 10 is false, 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 true, true. False, 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 true, true. Right. Right. So if I can join with the, okay, that's fine. Can you all hear me? Yes, let me know. Can you all hear me? Oh, it's fine, right? Yes. Okay, fine. Thank you. Right. Okay. So the question number 10 answers are question number 10 answers are false, 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 true, true. Right. Question number 11. Endometrial carcinoma. Right. Endometrial carcinoma associated with prolonged use of IUCD. What do you think? Associated with prolonged use of IUCD. Endometrial carcinoma associated with prolonged use of IUCD. Kavinder?
False.
That's false, no? So because any condition which lead hyperestrogenic exposure which can cause endometrial carcinoma, right? Any condition which lead hyperestrogenic exposure which can cause. So in IUCD usage, there is no hyperestrogenic exposure, right? So then that is false. Yeah, that's false. Common age in 40 to 50. Common age is 40 to 50. Yeah, that is false because the common age is 90% of the endometrial carcinoma occur in postmenopausal ladies. Right, 90% occur in postmenopausal ladies. So it's in the later age, not in the 40s to 50s. That is false. Related with the granulosa cell tumors, right? There are spelling mistakes. So the granulosa cell tumors, that is true because the granulosa cell tumor will produce the estrogen. Unopposed estrogen therapy will be a risk factor for the endometrial CA. That is true. Combined oral contraceptive pills with associated with risk. What do you think? That is false. Combined oral contraceptive pills has progestin. Always progestin has protective effect against endometrium. So that is false. Chemoradiation is the mainstay of treatment. What do you think? Karunanidhi Sivadeepan. What do you think? Chemoradiation is a mainstay of treatment. So what is the mainstay of treatment? Yes, come in. What is the mainstay of treatment for endometrial C? Very good. It's a surgical, right? Surgery. Surgery is the mainstay of treatment. If it is an extensive disease, yes, then we may have to think about the this one, chemoradiation. Otherwise, surgical is the mainstay of treatment. So that is false. False, false, true, false, false. So as we are closer to exam, so I'm doing bit fast. So what you can do is I'll send the paper previous day of the paper class. So please try to do the paper, right? So because if I'm doing the paper, if I'm doing very fast without making you to think, so then what will happen? So you might only just concentrate the answers and you just go without thinking. So that is not going to work, right? So you need to think before I explain, right? So please try to do the paper first. So then when I'm doing, just mark your answers and just think why you did wrong answers, right? So then if you have queries, if you have any explanation, you can ask during the class. Yeah, I will explain. It's not a big thing, right? So, but at the end of the class, you should be able to know what you are going to mark it. What are the answers it's wrong, why you are rejecting, because of course, so now from today, I'm going to do the papers like this and it's going to be a targeted question. So those questions will appear in your exams, right? So, right? So, so you need to do a lot of exposures, right? So now, so I had a plan how to teach to the students, right? So at the beginning, if I do very fast, you people can't understand. So you need to have a repetition. Now this is the time. So now we have another 1 more month. This is the time for the final touch. So we are just doing very fast, doing paper. So don't interrupt my plan. So at the the beginning, if I do papers like this, then that's not going to be useful for you. Now we have done so many papers. Now we have done the theory. You have a knowledge. Now this is the time for the target paper. Now we are doing very fast, right? So this question will come. So then we are just recalling and compare yourself. So then as I'm telling, I will tell the success of my teaching tomorrow after the KDU results, right? So then you will realize how success the way of teaching. So don't memorize without anything, because I know something, but I can't tell until tomorrow the results comes officially. So then I will tell the success rate. You should know how to pass the exam so they don't regret once you fail, right? So first you have to study thoroughly and finish it off this exam this time, right? Now this is the time. So thereafter, so all the class, it's going to be like that. So I will do the target questions quickly, relevant explanation only. I'm not going to teach the earlier. What I did is I just repeat everything to you. So if it is a CTG, I teach CTG again. So now the Charitra might have the experience 3 times, 4 times regarding SGA, 3 times, 4 times regarding CTG, 3 times, 4 times regarding preterm. So indirectly, the things might enter in your brain. Now, when you do questions without knowing, even you might not study something, but it's coming out. Do you understand? Now, this is the time to do the paper. So from this week, the final finishing, right? So we have to do the very fast things to the exam. This is how we need to prepare. So the exam preparation is an art. It's not the way what you are doing. So first slow, study theory, revision, do some papers. Now the final part is paper. Now it's a revision. We are doing paper, backward go and see your theory. Paper, backward go and see your paper, theory. So once we finish the paper, you go and revise your notes again. So then nothing, right? So how to advise, how to do the last more? Yeah. So after finishing this paper, I will give some idea how to utilize this last month for your all subject. So I know how to pass the exam with minimal effect, right? That one I know, I'll tell you. Without doing very hard work, with a minimal effect, how to pass the exam, I'll tell you after the paper, right? Question number 12, anticoagulation in the pregnancy is recommended. So sometimes the pregnancy is a hypercoagulable state. So once she become pregnant, so there might be a high risk of thrombus formation. So in that case, right, so some additional risk factors might increasing the thrombus formation. So mothers who are having additional risk factors for the thrombus formation, sometimes we may have to give the anticoagulant to prevent the thrombus formation. So first thing is you need to know what are the thrombus risk factors for the thrombus formation. So at this level, you don't need to know much about this, but you need to know there is a guideline for DVT, prevention of thrombosis in RCOG, right? So they have mentioned there is a scoring system to give the anticoagulant, right? So if the scoring system is given as 4, the score is 4, then you have to give the anticoagulant from the antenatal period as well as the postnatal 6 week. If the score is 3, anticoagulant from 28 weeks and postpartum period up to 6 weeks. If the score is 2, postpartum period until 10 days. Score is 1, you don't need to give the low molecular weight heparin, but you may have to give the additional maneuver like early mobilization, hydration, and things like that, right? So what are the systems? So what are the things can give rise to score 4? One is previous thromboembolism, unprovoked previous thromboembolism, right? So APLS, right? So prosthetic valve. So those are score 4. So it means if somebody has previous history of thromboembolism, there is no doubt. Immediately you have to start the aspirin. Not aspirin, low molecular weight heparin. Right? So factor 5 Leiden mutation. There is no doubt. You have to start. Do you understand what I'm telling? Right? So some conditions give score 3, like family history of the previous history of provoked thromboembolism. What do you understand by provoked thromboembolism? So somebody had a surgery and on bedridden for a long time and developed thrombosis. That is provoked thromboembolism. That is score 3. Right? Some scoring systems are giving score 2, 1, like obesity. Obesity more than 40, score is 2. Right? Obesity more than 30, in between 30 to 40, score is 1. Multipara score is 1. Right? So elderly mother, score is 1. Right? So like that, they are a scoring system. So here it's depend on the score. So here they're asking mitral valve prolapse. So mitral valve prolapse is a normal variant. So most of the women might have mitral valve prolapse, which not need anticoagulant therapy. That is false. Valvular varicosities, the score is 1. Varicose vein, what will happen? The blood is accumulating, so the score is 1. For the score 1, you don't need to give. So in addition to this valvular varicosity, multiparous woman, 5th pregnancy, 40-year-old, and BMI 35. So how many scores she is having? Varicose 1, multipara 1, obesity 35 is 1, and 40 years 1. So altogether, what is the score for she's having? She's having score 4. So then she need low molecular weight heparin. So only one risk factor is not a risk factor. It's not an indication. That is false. Antiphospholipid syndrome, yes. Antiphospholipid syndrome, the score is 3, and if it is a previous history of thrombosis with antiphospholipid syndrome, so definitely you have to start. That is true. Maternal beta thalassemia is a risk factor, but it's not an indication for the low molecular weight heparin. That is false. Aortic valve replacement. What do you think? Valve replacement? Kavinder? Valve replacement?
No, sir.
Yeah, that's true, because once you put the metal valve, the foreign body which can cause easily stimulate the thrombus formation, aortic valve or mitral valve, whatever the valve replacement, yes, it's a risk factor for the thrombus formation. You need to give the low molecular weight heparin, right? So good. Right? So the answers for question number 12, false, false, true, false, true. Right, fine. Question number 13, findings suggestive of ovarian CA in laparotomy. So what are the findings suggestive of ovarian CA, right? Blood strain peritoneal fluid, yes, we have discussed earlier also. So if it is a secondary to the peritoneum, so there will be hypervascularity and causing rupture of blood vessels and bleeding. So the ascitic formation with blood strain is a cause for, or it's suggestive of malignancy. That is true. Unilateral cyst, unilocular cyst. So that day I told you, if it is a multilocular cyst, it's a risk factor. Multilocular, especially more than 10 centimeter, is a risk factor. Multilocular less than 10 centimeter, also not a risk factor, right? Multilocular cyst less than, more than 10 centimeter. Unilocular cyst even more than 10 centimeter is not a risk factor, right? Multilocular cyst, yes, it could be a malignancy. Involving both ovary, yes. Bilaterality is a risk factor or is a feature suggestive of malignancy. Bilateral cyst is a feature, right? Solid and cystic area, yes. Solid area is a risk factor. Irregular liver nodule, what do you think about that? It's a feature of metastasis, right? It's a feature of metastasis. So if you can feel a irregular liver nodule, that's suggestive of secondary, so it's malignancy. So the features suggestive of malignancy in laparotomy: blood stain, ascitic fluid, bilateral cyst, multilocular cyst, solid areas, secondaries anywhere in the peritoneal cavity, right? Like liver, spleen, bowel, omentum, right? Mesentery, anywhere in the abdominal cavity. These are the features of malignancy in laparotomy, right? So it's a straightforward question. So if you see my notes in the book, so I have mentioned everything. The features suggestive of history suggestive of malignancy, examination features suggestive of malignancy, ultrasound features suggestive of malignancy, then finally the laparotomy features suggestive of malignancy. So it's the way to study in an exam oriented manner, right? This is how you will get the exam questions. This is how they will ask in the exam, so in Viva. So okay, once you do examination, what are the features you are looking to confirm the malignancy? Then you have to know what are the features. So you have to organize. So I have reduced your workload. I have organized everything from different books and given as a summary. So then you don't need to read and organize it. You just read and understand and keep it in your mind. That's it, right? So the answer for question number 13, true, false, true, true, true. Right, gonorrhea. Diagnosed by presence of intracellular gram-negative rod. Yeah, that's true. Right, it's a diplococci. So they mention rods. It's a diplococci, right? Gram-negative diplococci, coccus. Right, so adequately managed with ciprofloxacin, Cipro 500 milligram in a single dose for sensitive strain. What do you think? What is the answer for this? B. Adequately managed with ciprofloxacin 500 milligram as a single dose of sensitive organism. Yes. So Nuwandi is asking in question number 13 if they simply mention multilocular cyst. Is it true? Yeah, we will take it as true because multilocular. So in case of if it is more than 10 centimeter, high likely, but if it is a multilocularity, it's a risk factor. Oh, it's a feature of we can't take it as false as well. So that's why we are taking as true. So question number 14, answer B, the stem B, adequately managed with Cipro 500 milligram as a single dose for sensitive strain. Yes, that is false, right? So ceftriaxone, very good, Sivadevan, right? So the single dose of ceftriaxone 500 milligram, that is the dose, not the ciprofloxacin, right? For the gonorrhea, single dose of IM ceftriaxone, that's it. That is the only treatment, right? So single dose of ceftriaxone, that is false. Does not cause cervicitis. What do you think? So this gonorrhea and chlamydia infect the column epithelium. Gonorrhea and chlamydia infect the column epithelium. So wherever you are having column epithelium, will it infect that area, right? So for example, so your cervix has column epithelium, endometrium has column epithelium, tubes has column epithelium, right? So your peritoneum has columnar epithelium, so which can cause ascending infection to cervix, cervicitis, endometritis, salpingitis, oophorytis, peritonitis, like that. Right? So your vagina doesn't have columnar epithelium; it has squamous epithelium, so it won't infect the vagina. So the vaginitis, it's not a feature of gonorrhea. Do you understand what I'm telling? Because they doesn't have the columnar epithelium. Okay. So what about the urethra? Do you have columnar epithelium in the urethra? Do you have columnar epithelium in the urethra? Urethra? Yes, yes, yes. Aguila, what do you think? Do you have columnar epithelium in the urethra? Yes. We are having columnar epithelium in the urethra. That's why the gonococcal infection can cause gonococcal urethritis, right? Urethritis. So the urinary tract infection is present in more than 50% of the gonococcal infection because columnar epithelium, which has columnar epithelium. Do you have columnar epithelium in the anal canal? Rectum? Yes, we are having. So the people who are having anal sex, high risk to develop bronchitis. Why? Because they are having columnar epithelium. Then your gonococcal infection can infect the anal canal. Like people who are having oral sex, right? I don't know sure even. So the people who are having oral sex, your pharynx will have the columnar epithelium, so then they can have gonococcal pharyngitis. So everywhere they are having columnar epithelium, they can have an infection. So does not cause cervicitis. That is false because cervix has columnar epithelium, so cervicitis is possible. That is false. But does not cause vaginitis. What do you think? Does not cause vaginitis. True or false? Yeah, that's true because vagina doesn't have columnar epithelium, only squamous epithelium. So vaginitis is not possible with the gonococcal infection, right? Okay. So could be isolated from Bartholin abscess. What do you think? Could be isolated from Bartholin abscess. Earlier I searched for this answer, I couldn't find the answer, but recently I read a TOG article, so it's nicely mentioned. So you can see in the Bartholin gland, right? So the secretory duct as well as the Bartholin gland will have columnar epithelium. Agreed. So as they are having columnar epithelium, it can be present in the Bartholin gland, right? So it can be present in the Bartholin gland. So we have to mark it as true for this step, because as it is affecting, so the columnar epithelium, right? So which can cause infection into the Bartholin abscess as well. So that is, we have to take it as true. Could be isolated from the rectal swab. Yeah, that's true. Because I told you, it can cause bronchitis, urethritis, cervicitis. So where you can take the biopsies or sample, you can say take the sample from the urethra or anal canal or maybe from the cervix, right? High vaginal. Will you take high vaginal swab for the gonorrhea? Very good, Praglada. No, because it's not causing infection in the vagina. So then what's the point of taking the high vaginal swab? So will you take the low vaginal swab for the gonorrhea? Ayesha, true. Yes? Yeah. Low vaginal swab, you can isolate sometime. The reason is the organism from the urethra as well as the anal canal might come to the lower part of the vagina. That's why sometimes the low vaginal swab can be positive for the gonorrhea. So try to understand the stuff rather than memorizing, right? Okay, fine. So the could be isolated from rectal swab. That is true. Right. Question number 15. Infection which cause fetal anomaly include. So what are the infection causing fetal anomaly, right? Infection which cause fetal anomaly include, right? So gonorrhea. So the gonorrhea will not cause fetal anomaly, which can cause gonococcal infection to the baby, pneumonia, meningitis, right? So conjunctivitis while the baby is coming through the birth canal with the infected mother, which can cause infection into the baby's fetal columnar epithelium. What are the columnar epithelium part will expose to the fetus? So your conjunctiva, right? So the pharyngitis, lungs, brain, right? So those are the possibilities. But it will not cause any congenital abnormalities to the baby. Hepatitis B can cause uh, uh, liver damage and hepatocellular carcinoma to the baby as well, but will not cause any long-term fetal anomaly, but which can cause IUGR. So then we have to take it as false. Parvovirus, again the same thing. Parvovirus can cause aplastic crisis, so which can cause anemia, hydrophytalis. Not only the aplastic, also it has an effect on the myometrium, can cause myocarditis, right? It can cause myocarditis and the heart failure, which lead to hydrophytalis and fetal death, but which not cause any permanent damage to the baby. It means the congenital anomaly. So the parvo, it's false. Rubella, yes, we know the rubella can cause congenital abnormalities, and Toxoplasma gondii, yes, which can cause congenital abnormalities. So because torch infection can cause congenital abnormalities, as we studied, isn't it? And syphilis, in addition to that, syphilis. So the answers are false, 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 true, true. Right. Question number 16, progress of the labor is measured by. So how we are measuring the labor progression. So the labor progression can be measured by two ways. One, right? So if the labor is progressing, the cervix has to be dilated. That is one. Second thing, the baby has to come down, right? Baby has to come down, right? So baby has to come down. So the labor progression will be measured, right, with these two measures. With these two measures. One, we are assessing whether cervix is dilating. If the cervix is dilated, yes, we can say the labor is progressing. Second thing, we can assess the labor progression with the fetal descent. How to assess the fetal descent? There are two ways to assess the fetal descent. One, we can assess the fetal descent by the abdominal palpation. How many fifth is palpable? Earlier is 3/5 palpable abdominally, now 2/5 palpable abdominally, now 1/5 palpable abdominally, 0/5 palpable abdominally. It means baby is entering into the pelvis. That is one. Second thing, you can do the vaginal examination and assess the station. If the station is coming down, earlier it's -2, now -1, 0, right? And +1, +2, it's coming down. So the labor is progressing. These are the two methods to assess the labor progression. So rest of the things will not say whether labor is progressing or not. Whether uterus is contracting or not, that will not say whether labor is progressing or not. Because if the mother has cephalopelvic disproportion, right, uterus might contract very much, but labor will not progress because the space is not adequate. Do you understand what I'm telling? Right? So now the question is, progression of labor is measured by frequency of uterine contractions. So obviously no, because the frequency of uterine contraction will help for the labor progression, but labor progression can't be measured with the uterine contraction. Do you understand? Am I confusing? No, right. You will understand, right, Akila? Am I confusing? No, right, fine. Okay. So the force of uterine contraction, again the same thing. The force of uterine contraction or number of uterine contraction will help to progress the labor, but that will not help us to assess the progression, right? That is false. Dilatation of the cervix, what do you think? Cervix is dilating. Earlier 3 centimeter, now 4 centimeter, 5 centimeter, 6 centimeter, 7 centimeter. What is it indicating? The labor is progressing. Yeah, that's true. Descent of the presenting part. Yeah, the descent of the presenting part. So the baby is coming down. That is true. Length of the time since the rupture of membrane. Yeah, that will not, right? So if the membrane rupture, that will not say whether labor is progressing or not. So very good, right? So most of the students' facial expression is happy to me because you know the answer. The way you are responding is, so you are telling, so this question is bullshit, nothing like that. So it's good, very good. So the answer for question number 16, false, false, true, true, false, right? Question number 17, active management of third stage of labor involved. So there are 3 things in active third stage of management. If you know that, you can answer that. What are the three things? One, giving syntocinon when the anterior shoulder or immediately after the baby delivery. Second, delayed cord clamping. Third one, controlled contraction once the uterus contracts. Right? Controlled contraction once the uterus contracts. So we just palpate the uterus. Once the uterus become hard and globular, the features suggestive of uterine contraction. So that is the time you need to pull the placenta out. Do you understand what I'm telling? Once you find the features suggestive of uterine contraction, you need to give the controlled contraction. So will you give the uterine massage, fundal massage, in third stage of management, fundal massage? Will you give? So the routine fundal massage is not recommended in third stage of management. The fundal massage will be offered if the mother has PPH. If the mother develops PPH, we do massage. Otherwise, don't do massage. Right? Okay. So now if you know those things, now we can do the question simply. Administration of 0.5 milligram ergometrin. Will you give ergometrin? No, we are giving syntocinon, not the ergometrin. That is false. Observing for the signs of placental separation. What do you think? Once the sign of placental separation, gush of blood comes, lengthening of cord, once the placenta separates, then you are giving the controlled contraction. So actually, observing for the signs of placental separation is a feature of passive third stage labor, right? So we are not waiting until the separation. Once the uterus contract, we are just pulling, right? So once the uterus start to contract, then of course your placenta also start to separate, and of course you can see the gush of blood and lengthening of cord, everything will be there. But we are not waiting until the signs of separation. Sometimes placenta might not separate, but uterus might contract, then you are giving the controlled contraction. That is your active third stage labor, right? So observing for the signs of placental separation, it's not we are checking during the third stage, but that is not a part of active third stage management. So you have to answer for this question, right? That is not a part of active third stage management. Manual removal of placenta if not separate after 25 minutes. What do you think? If it is more than 30 minutes, that's called prolonged third stage labor. After delivery, if it is prolonged more than 30 minutes, then you can say prolonged third stage labor. So then we have to do some maneuver first. We give the aspirin, so this syntocinon infusion, right? So then we are applying the as ice pack, right? So then intracord. So if you read the national guidelines, still we are practicing the intracord syntocinon. Through the umbilical cord, we are giving a syntocinon 40 unit and waiting for another 30 minutes to do the manual removal. But the newer guidelines which we are practicing in UK, they are not practicing the intracord syntocinon in UK nowadays. But in Sri Lankan guideline, it's there, and some units are practicing the intracord syntocinon. So if the placenta is not separating, we are giving 40 to 50 units syntocinon through the cord and wait for 30 minutes, then placenta will separate. If not, then you put your hands inside and do the manual removal. That is how we are managing, right? So the manual removal of placenta, if not separated after 25 minutes, that is not the active third stage of labor. That is false. Application of controlled contraction if the uterus is contracting. What do you think? Yeah, that's true. Massaging the fundus, fundal massage. Fundal massage? I told you, fundal massage, it's not a part of third stage of labor. If it is a PPH, yes. So answer for this question number 17, false, 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 true, false. Question number 18. Female with primary pregnancy at term presented with oblique lie. Right, so usually in term, for the primary, head will engage. Right, here for the primary at term, head is not engaged, and furthermore, the baby is in oblique lie. It means the lower part is not adequate or not allowing the baby's head to enter into the pelvis. Agree? That is the message you need to understand here. Even at term, the lower part is not allowing the fetal head to enter into the pelvis. There might be some problem. So has to exclude placenta previa. What do you think? Yeah, of course, because the placenta might interrupt to enter the baby's head into the pelvis. That is true. Can be delivered by induced oxytocin and amniotomy. What do you think? Can you do the amniotomy for the oblique lie? So obviously we can't, because if you do that, what will happen? There is a high risk of cord prolapse, isn't it? So this is your uterus. Now the baby is like this, right? So your cord might be like this, right? So then once you rupture the membrane, then cord will come out. So you can't do the induction as well as the artificial rupture of membrane for the oblique lie. That is false. Can be managed in home until the labor pain appear. That is false, because if the labor pain appears, there is a high risk of uterine rupture as well as the cord prolapse. So if it is an oblique lie or transverse lie, we usually electively admit around 38 weeks and keep the patient in the ward, right? Either you can do the ECV after excluding the placenta previa and the lower segment fibroid and uterine anomaly and the fetal anomaly. You can do ECV and try to deliver vaginally. If not, you may have to go for a cesarean section, right? Because if the lower part is not adequate to allow the normal vaginal delivery, what is the point of doing ECV? No point. You have to go for a cesarean section. For example, placenta previa. If the placenta is occluding the lower segment, lower part, will the normal delivery is possible? No. So then you may have to go for a cesarean section, right? So if it is no contraindication for normal vaginal delivery, then you can do the ECV and deliver. If it is a contraindication or ECV failed, then you may have to go for a cesarean section. But whatever, you can't keep the mother at home until the labor pain starts. You may have to have the elective admission since 38 weeks if it is a transverse lie or oblique lie at home. Right. So can we manage in home until the labor pain appears? That is false. Fetal anomaly should be excluded. Yes, that's true, because one of the cause for the oblique lie at term could be maternal anomalies like uterine anomaly, fibroid, or placenta previa, or CPD, or maybe a fetal problems like hydrocephalus and encephaly, like that, right? So which can inhibit the baby to enter into the pelvis. So the fetal anomaly should be excluded. Yeah, true. If the membrane rupture, cord prolapse should be excluded. What do you think? Yeah, that's true, because as I told you, the lower part is empty. Once the membrane rupture, cord will come out. So first thing, if you are a house officer, first thing you have to exclude the cord prolapse. Right, fine. So the answer for 18 is true, false, false, true, true. Question number 19. The physiological mechanism which facilitate the placental transfer of oxygen include. So from the mother, baby is going to get the oxygen, not like in the lungs. In the lungs is getting oxygen from the atmosphere. So in atmosphere, you are having high oxygen partial pressure. You are having high oxygen partial pressure. So the oxygen transport from air to the bloodstream is going to be a simple event because oxygen partial pressure is a bit high. But in fetal circulation and the maternal circulation, as we know, right? So this is the placenta. This is the fetal RBC. This is the maternal RBC. Now, the maternal RBC has oxygen. Yeah, this is the oxygen, the maternal RBC. Actually, this oxygen should be picked by this fetal RBC. This is how the oxygen transport will occur in the maternal circulation to fetal circulation. Do you understand what I'm telling? So, if this fetal RBC want to drag the oxygen from the maternal RBC, already it's attached to the maternal RBC. So this fetal RBC is going to take from the maternal RBC. So then the fetal RBC should have more affinity. Agree? More affinity to pick it from maternal RBC. That is one. Second thing, the maternal RBC should be able to release the oxygen easily. So easily detachable. then only that one can easily get it. Right? That is second. Third one, so if mother has less RBC, 100 RBC, the fetus has 200 RBC, then the carrying capacity will be high, then oxygen transport will be high. You understand? And third one, if you increase the blood flow to the placental site, what will happen? Oxygen delivery to the placenta is going to increase and oxygen supply is going to increase. You understand what I'm telling? Those are the ways the fetal circulation getting oxygen supply consistently during the interpartum and antenatal period. So the physiological mechanism which facilitate the placental transfer of oxygen include presence of HbF. Yeah, that's true, because HbF in the fetus has high affinity to the oxygen, than the adult hemoglobin. Do you understand? So if you are too handsome, then you can pick from someone easily. Am I agree, Kavinder? Are you agree, Kavinder? Yeah? So the fetal RBC has high affinity towards the oxygen, so then it can easily pick the oxygen from maternal RBC. Do you understand? So HbF, presence of HbS is one of the physiological adaptation. Increased concentration of hemoglobin in the fetal blood. Yes. So the normally maternal hemoglobin concentration may be 10 to 12. The fetal RBC hemoglobin around 18. So the RBC concentration is very high. So then transport will be more. Reduced level of 2,3 BPG in maternal blood. What do you think? True or false? Kavinder? Reduce 2,3 BPG in the maternal blood. True or false? What is the function of 2,3 BPG? What is the function of 2,3 BPG? If you don't know, then you can't answer for this question. What is the function of 2,3 BPG? Praga, what is the function of 2,3 BPG? So the function of 2,3 BPG is, right? So detach the RBC, detach the oxygen from the release the oxygen from the RBC, right? Release the oxygen from the RBC. So what will happen to the 2,3 BPG to the maternal circulation during pregnancy? What has to be happen? 2,3 BPG level should goes up, then only it will increase the release of oxygen to the fetus. So 2,3 BPG level will goes up in pregnancy to the mother. It will not reduce. That is false. Constriction of the spiral arteries. Yes. If the spiral arteries are constricting, what will happen? Blood flow to the placental bed is going to reduce. Then oxygen supply is going to reduce. So the spiral artery should dilate. That's why the spiral arteries are ending as sinuses. Very big pool. So then easily blood can enter into the placental bed. So constriction of spiral arteries, false. Increase uterine flow. What do you think? Yeah, obviously that is true. If the blood flow increase to the uterus, then of course your oxygen supply will go up. So that is true. So the answers for 19, true, true, false, false, true. Question number 20, menorrhagia is recognized feature of adenomyosis. Of course, that is true, because adenomyosis will present with menorrhagia as well as dysmenorrhea, right? So it's a recognized feature of adenomyosis too. Associated with hypothyroidism. Menorrhagia associated with hypothyroidism. Any kind of thyroid abnormality can present with menorrhagia. With the hypothyroidism, right? So you have to keep that in your mind like this. Thyroid abnormality can present with menstrual abnormality. What I am trying to say is hypothyroidism or hypothyroidism can cause menorrhagia or hypomenorrhea. Both can cause heavy menstrual bleeding. Both can cause oligomenorrhea as well. Right? So you can answer like that. So thyroid abnormality can cause menstrual abnormality. Any kind of abnormality. Both. Hyper and hypo can cause both. Okay, fine. So associated with hypothyroidism, true. Commonly seen in PCOS. Menorrhagia commonly seen in PCOS. That is false. So menorrhagia, it's less likely in PCOS. They can have menorrhagia, But common feature, common menstrual abnormality in PCOS is oligomenorrhea, less bleeding, right? That is false. Investigated with diagnostic curettage in 30-year-old patients. So menorrhagia, why we are investigating with curettage? To take the biopsy, endometrial biopsy. So why we are taking the endometrial biopsy? To exclude the malignancy. So when we are having high risk to have malignancy in postmenopausal or perimenopausal ladies, maybe around 45 to 50, 55 years, yes. But if it is a 30-year-old lady, it's less likely to be due to malignancy until she has a strong risk factors for the malignancy, like strong family history of malignancy, very thickened endometrium, obesity, like that. So if she has very strong risk factors, then of course you have to think about the biopsy. Until that, for a young woman, you don't need to think about the biopsy. If it is 45 years, always you have to exclude the malignancy first before you start any treatment. But if somebody present with menorrhagia at 30 years, then it's less likely to be malignant. You can start the OCP and control the blood menorrhagia, right? So this is a very important point for you to do the private practice as well. So last week I have seen one patient. So patient had a postmenopausal bleeding. For 2 years, somebody treated the patient with an aldosterone for 2 years. Postmenopausal bleeding, some general practitioner treat the patient with aldosterone. So when she come to the clinic last week, she had grade stage 3 cervical malignancy. Stage 3 cervical malignancy. So when she present with postmenopausal bleeding at 2 years back, if we diagnose the cervical malignancy, it might be a stage 1 and it is a good prognostic one. Now it's stage 3, probably she will die in 6 months' time. So it's not the death, it's a murder. Like the medical officer who are not aware about the genotypes. Do you understand? Don't be like that. So we are seeing the patient like that. Okay? So last week I have seen a patient like that. Okay. So investigate with diagnostic curettage in 30 years, that is false. Treated with mefenamic acid, what do you think? So the mefenamic acid treatment for the dysmenorrhea, not for the pain, not for the bleeding, right? So tranexamic acid, mefenamic acid, we don't give the mefenamic acid for the purpose of menorrhagia treatment. Yeah, that's false. So the answer for question number 22, true, false, false, false. Question number 21, antenatal care will reduce the incidence of, it's a nice question. Antenatal care will reduce the incidence of eclampsia. What do you think? Yeah, that's true, because if you have a proper antenatal care, what you will do, you will assess the patient with the risk of eclampsia, then we start aspirin, we give high dose of calcium and preventive measures for this eclampsia, and we are monitoring the blood pressure, right? And once the blood pressure goes up, then we are screening for the pre-eclampsia with urine albumin. If urine albumin positive, then we start the max sulfate to prevent the eclampsia. So if you have a proper care, you can prevent the eclampsia, agree? Yeah. So then, so your antenatal care will reduce the incidence of eclampsia, obviously true, isn't it? Yeah. Intrauterine death, what do you think? Obviously, because you are looking for the risk factors for the intrauterine death, like diabetes. So if you properly diagnose the GDM with a proper antenatal care, then you can prevent the intrauterine death. Otherwise, mother will present with the intrauterine death. That time when you check the blood sugar might be very high, right? So the antenatal care will prevent the intrauterine death. That is true. Meconium aspiration, what do you think? So the meconium can be a feature of fetal distress. So that is intrapartum or maybe something. So it's an acute event causing meconium passage. Meconium is the fetal feces. Meconium passage, and baby might aspirate that meconium. So the fetal distress and meconium aspiration, it can't be prevented from the antenatal care. But what you can do, you can provide, or you can minimize the fetal death by providing the cesarean section if it is a meconium strain lipo during the intrapartum period. So institutionalized deliveries will reduce the meconium aspiration, true or false? institutionalized deliveries will minimize the meconium aspiration. True or false? Charita, yes, good. It's true, because if somebody deliver the baby at home, no one will identify the meconium and no one will do the cesarean section. If somebody delivered at hospital, that is institutionalized delivery, hospital. So then once we do the ARM, we can identify the meconium. Once it's meconium, then we can do cesarean section and prevent the aspiration, and we can reduce it. So you can't say antenatal care, it's not institutionalized delivery. Yeah, it's a one part of antenatal care, but this question is some kind of confusing thing. So antenatal care will reduce the incidence of meconium aspiration. So the throughout the care will not reduce, but institutionalized delivery, yes. So, but we will take it as false for this statement, right? Multiple pregnancy, antenatal care will reduce the multiple pregnancy. What do you think? That's false, no? It's false. So the placenta previa, antenatal care, if you give the proper antenatal care, can you reduce the placenta previa? That's false. So the answers are true, true, false, false, false. Question number 22, causes of anovulatory infertility. So the infertility causing due to an ovulation. Endometriosis, what do you think? In endometriosis, there is no problem with the ovulation, something problem with the tubal factor and the dyspareunia, right? So that is false. Obesity, yeah, obesity can cause anovulation. That's true. PID also same as endometritis. So the endometriosis. So that can cause tubal disease and the dyspareunia, dysmenorrhea, but it won't cause any abnormalities or any problem with your ovulation. So ovulation is usually normal. So PID false. Polycystic ovarian syndrome, around 90% of the anovulatory infertility is due to PCOS. So that is true. Prolactinoma, again, the prolactin will inhibit the GnRH secretion, FSH secretion, as well as it's inhibiting the FSH activity on the ovary. So the prolactinoma, hyperprolactinemia is a risk factor for the this one. What is that? Is a risk factor for the anovulatory subfertility, right? So the answers are false, true, false, true, true. Abnormal parameters of the, not the SPA, so there is a spelling mistake. Abnormal parameters of the SFA, seminal fluid analysis, right? SFA, seminal fluid analysis, not the SPA, SFA, seminal fluid analysis. So there are 6 parameters you need to remember. I'm always repeating, just memorize one. The total ejaculation should be more than 39 million per ejaculate. O, sperm concentration should be more than 15 million per milliliter. Total motility should be more than 40%. Linear motile should be more than 32%. The normal form should be more than 4%. Right? Volume should be more than 1 milliliter. pH should be more than 7.2. Vitality should be more than 58%. Right? Vitality should be more than 58. These are the normal parameters of the SFA. So here they mentioned sperm count of 30 million per milliliter. Sperm count of 30 million for milliliter. So the abnormal feature. So if it is 30 million, means more than 15 million. So it's not an abnormal feature, it's a normal feature. Do you understand? Yeah, that is not the abnormal feature, so false. Sperm motility of 50%. So if the sperm motility of 50% means it's normal feature, because more than 40% it's normal. So then you can't take it as abnormal. Sperm with abnormal morphology of 50%. Is it normal feature or abnormal feature? What is the minimum amount of normal form, normal morphology? 4%. So you can have 96% abnormal sperm. Here they are having only 50% of abnormal sperm. So it means, is it normal feature or abnormal feature? Yes. Abnormal morphology of 50%, it's a normal one, because up to 96% of abnormal, it's normal. So if it is 50% mean it's normal. So this is false. 6 to 7 pus cells, even a single pus cells is abnormal. You can't have, because the sperm is a sterile one. Sperm is sterile, right? So not like vagina. Sperm is sterile, right? So you can't have pus cells. If it is a pus cells, then of course you have to treat them. Volume more than 2 ml, yeah. If it is more than 2 ml, it's normal. So you can't say it's abnormal, right? So somebody has doubt. The stem A sperm count 30 million per milliliter. So the count, the word count is confusing, but if you see the value 30 million per milliliter, means that is concentration. The total count say 39 million per ejaculate. Here they didn't mention about the ejaculation. They mentioned 30 million per milliliter. It means concentration. So the concentration should be more than 15. So here they mentioned 30. So then we have to take it as normal. So it's false. So the answer for the question number 23, false, 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 true, false. Question number 24, urgency in maturation. Urgency, urge to pass urine. So idiopathic detrosmuscular instability, because the urge to pass, unnecessarily the detrosal muscle is contracting. So the detrosal instability is one of the major cause for the urgency incontinence. So that is true. UTI, yes, again true, because the cystitis can cause irritation in the detrosal muscles, which cause unnecessary contraction of detrosal muscles. That is true. Urodynamic stress incontinence. In stress incontinence, the detrosal muscle is not contracting. Actually, they are leaking the urine because of laxity in the urethral sphincter. Right? So that is not the urgency, that is stress-related urinary leakage. That is false. Urinary calculi, what do you think? Urinary calculi. Can it cause urge incontinence? Yeah, it can cause, because the calculus can irritate the detrosal muscles and cause urge incontinence. That is true. Multiple sclerosis, any neurological condition which can cause urge incontinence, like diabetes, multiple sclerosis, yes, which can cause urinary incontinence. That is true. So the question number 24 answers are true, true, false, true, true. Question number 25, recognize cause of vesicovaginal fistula. Vesicovaginal fistula, it means the fistula from bladder to vagina, right? Obstructed labor, what do you think? Obstructed labor. Sivadeepan, today you are behind the screen. Even though it's free class, you have to come. Obstructed labor, what do you think? That is true, because when it is an obstructed labor, right, the baby's head will, hello, welcome, right? If it is obstructed labor, the baby's head will compress the bladder, okay, for a long time. When the bladder is get compressed for a long time, right, what will happen? The blood supply to the bladder is going to cut down, right? So when the blood supply cut down, the particular area is going to have the necrotic change. The vagina and the particular bladder area is going to have the necrotic change. The necrosis which lead healing. While the healing occurs, these two mucosal area will form a canal. That is your fistula. So the obstructed labor is one of the feature, or one of the complication, or one of the risk factor for the vesicovaginal fistula. That is true. Abdominal hysterectomy, yes, abdominal hysterectomy, vaginal hysterectomy, laparoscopy hysterectomy, those can be a risk factor for vesicovaginal fistula. Radiotherapy, again, same thing. When you give the radiotherapy, the radiation will cause necrosis of the bladder as well as the vagina, and there will be a connection. Yeah, radiotherapy is a risk factor too. Ulcerative colitis or Crohn disease. Ulcerative colitis or Crohn disease, what do you think? that is false. In ulcerative colitis and Crohn's disease can cause enterovesical fistula from the gut to bladder, right? Entero, gut to bladder, maybe anal or maybe small bowel or maybe or your sigmoid colon, enterovesical fistula, right? Not the vesicovaginal fistula. Cervical CA? Cervical CA? Gayandi, what do you think? Cervical CA, can it cause vesicovaginal fistula? In cervical CA, what will happen? The malignant tissue will infiltrate into the vagina as well as the bladder. So simple, no? What once the malignant, so both tissues are infiltrating, then there will be a connection. So the cervical CA is a risk factor for vesicovaginal fistula. So the answers for 25th is true, 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 false, true. Any doubt in MCQ? We have done 25 MCQ. Even if you want, I can do 60 questions in 2 hours. It's not a big thing, isn't it, Lango? Raga. Yeah, but the thing is, now if I'm doing bit fast, you people can understand because already you have studied, we have revised a lot. So we have done the theory, revision, right? Topic-wise revision, everything. Now you all know the theory. So then if I'm telling something like the terminologies, yes, this is, so the juniors, even juniors know the stuff, the people who are waiting for the exam. So then I can do paper like this very fast. So the coming classes will be like this because this is the time to do like this. So we can't do very fast at the beginning. So if you're expecting, that is kind of business. That is not the business. The purpose of doing the classes make you to pass. I need to have the high rate of pass rate because I got the money from you. So that money, so that there should be a, you spend that money, you have to get the benefit for that money. That's my policy. Then only that money will stay with me, isn't it? So I have to give the maximum effect for that. Otherwise, it's not going to stay with me, right? So you also have to work hard and help your parents, right? Finish it off. Right. We will move to SBA. So SBA, up to which question we have done? We have done 6th one, isn't it? Or do we want to do 6th one today? We have done 6th. We'll start from 7th. Okay, fine. Right, 7th. Question number 7. A 40-year-old woman complained of postcoital bleeding. Speculum revealed lesion on the upper lip of the cervix with contact bleeding and surface ulceration. What is the next step of management? Yes, my dear students, answer please. B, B, C. Go. Quickly answer. Come in there. What's your answer?
C, sir.
Huh?
C.
Okay. So the patient presented with postcoital bleedings, 40 years. So one of major differential diagnosis for this condition is going to be cervical CA. So what are the other differential diagnoses with the postcoital bleeding? So because no point in, for the SBA, I will spend some time. So I can finish the paper today if we have time. So because I need to explain how to tackle the question. So MCQ, it's not like that. So if you know the stuff, you can. But SBA, it's not like that. If you know the stuff, even you can't find the answer properly. So the way of approaching the question and way of thinking and rational way of answering, those are the things, right? Okay. So here, the postmenopause, postcoital bleeding, what are the possible causes? One is your in cervical CA. Other than that, what are the other differential diagnosis? Once you come to the Viva class, you have to take the history to exclude the other differential diagnosis like this. Until you know the differential diagnosis, you can't take the history. So maybe after October, first or to second week after the exams, you are coming for the Viva exams. So then you need to prepare yourself for that also. Sometimes if you have less time interval, then you have to organize your theory knowledge to the Viva as well. So what are the differential diagnoses? Could be endocervical polyp, post-cervical infection, cervical trauma, cervical ectropion, isn't it? Right? So those are the different diagnoses for the postcoital bleeding. Right? So here, the first thing you need to exclude the malignancy. So to exclude most of the things, the simple way, you just examine the cervix with your speculum. Just see the cervix, what is happening. If it is a malignancy, there might be a lesion. If it is an infection, you can find the inflammatory features like reddish color, discharges, right? So bad odors, things like that. Right? If it is an ectropion, you can see the ectropion, very reddish lesions. Right? If it is a trauma, you can see the trauma. So the simple most examination you have to do for this patient is the speculum examination. Right? So if it is a malignancy, right, so you can see the malignant lesion obviously in the cervix. Sometimes it could be a early malignancy like stage 1A, might be a microscopic lesion, 3 millimeter lesion. So in that case, sometimes you might not see the lesion. Or sometimes if it is a pre-malignant lesion like HSIL, you can't see the lesion because it's macroscopically normal. Do you understand? Macroscopically normal. If it is macroscopically, if you can see a lesion, then what is your first aim? You need to exclude that lesion, whether it's malignancy or not. Because you know the abnormal area, you can see the abnormal area, you need to exclude it whether it's malignancy or not. How can you exclude whether it's malignancy or not? You can take a piece of tissue from the abnormal area and see it. That's it. Right? So if you want to take the piece of tissue, you have to take from that particular area. So if you want to cut the nail, you don't need to cut the finger. Agree? You have to cut the nail only. So if you have an abnormal area, you can take the piece of tissue from the abnormal area. That's it. So if you can't see an abnormal area, then it could be a pre-malignant lesion. So in that case, it could be a microscopic lesion. In that case, you need some special test. You need some special equipment to see the abnormal area. So what is the special equipments we are using to find out the abnormal area in cervix?
Colposcopy.
Very good, colposcopy. We are just putting the camera and magnify the cervical image and apply some chemicals to see differentiate the abnormal area like acetic acid and lugoladin and find out the abnormal area and take the biopsy. Agree? So here they have mentioned postcoital bleeding speculum examination reveal the lesion on the upper lip of the cervix. So it's a macroscopic lesion. We know there is a lesion. So what is your next part? You need to take the piece of tissue from the lesion. That's it. No need to think too much. Right? So it's a cone biopsy mean you are taking entire transformation zones, the large portion you are taking. No need to take a large portion. The lateral part, lower part, you don't need to take. So here we know there is an abnormal area. Take a piece of tissue from that abnormal area and identify whether it's abnormal or malignancy or not. If it is a malignancy, then you can stage the disease. Depending on the staging, you can decide your management. Do you understand what I'm telling? Right? So what is the answer? What is the answer going to be? Now you can simply select the answer. If you understand the fact, there is no doubt. The answer is going to be C. Perform a batch biopsy from the lesion. But when you take the biopsy should take from the edge of the lesion. Why is that? Edge of the lesion. Anyone?
Center is necrosis.
Very good. Center part is necrosis, right? So for example, I'll show you nicely. This is the cervix. This is the internal os. You are having the lesion somewhere here. So if you take the biopsy from here, the center part might be necrosis. The cell's architecture might vary, altered. So then if you see under microscope with the necrosed cells, you can't identify the abnormality. So then if you take the tissue from the edge, so then those tissues are it's intact tissue, then you can identify easily. Do you understand? So answer is C. Question number 8. The male partner of infertile couple has sperm concentration of 10 million in 2 separate occasions, 3 months apart. The woman has 28 regular cycle. Investigations reveal regular ovulation and patent tissue. What is the next step of management? Yes, answer please. So this is basically a male factor infertility because she's having regular cycle, ovulation is normal, tubes are patent, so it means there is no ovulatory sufferability, no tubal factor sufferability, so the female is okay. But the male is the problematic one. Male has less sperm count, 10 million per milliliter, it's less than 15, so it's abnormal, oligospermia. But can you diagnose oligospermia or azoospermia with one report? No, you can't do. You have to repeat it 2 times. The repetition should be done in 3 months apart. Why? What is the reason?
Spermatogenesis occur after process need 3 months.
A single sperm production, that is called spermatogenesis, it takes almost 3 months. Right? Almost 3 months. That's why. So they don't waste the sperm. It takes 3 months to produce a single sperm. Do you understand? So it's take 3 months. So that's why you need to repeat the sperm full report or a seminal fluid analysis in 3 months. So the 3 months apart, 2 reports reveal oligospermia. So it means it's confirmed oligospermia. So if it is oligospermia, already we discussed, if it is less than 5, it's less likely to be pregnant, so become pregnant with the IUI either. But if it is in between 5 to 12, 15, so then you can do the IUI after preparation. So what we are doing in preparation, we are concentrating the sperm and increase the sperm count and concentration, and we are just injecting into the endometrial cavity that will increase the chance. So the answer is going to be artificial insemination after preparation of husband's semen. We do preparation. So in preparation, what we are doing is we are concentrating the sperm as well as we are removing the immotile sperm. Only motile sperm we are injecting into the endometrial cavity, so then it will move. And yeah, okay, somebody asked why the clomiphene, treat the male partner with clomiphene citrate. Clomiphene is wrong. So if you give the clomiphene to the male partner to increase the sperm count, what will happen? If you read the nice guideline for subfertility, right? So sometime if it is oligospermia, some center they are practicing the clomiphene citrate to increase the sperm count, but that is not recommended and it doesn't have much effect. There is no proven benefit, right? So the clomiphene citrate is not recommended for the oligospermia. Artificial insemination of the sperm, aspiration from the testis. Somebody asking why it's not B. What do you think? Artificial insemination of the sperm, aspiration from the testis. What do you think about this answer? Bumbly, yes. There are 2 things. One, if you aspirate from the testis, that sperm doesn't have motility. So then no point in doing IUI. That is one. Second thing, when you can easily collect the sperm by the masturbation, still you want to prick the testis and take it off. Huh? Without any pain, with the pleasure, you can take the sperm by masturbation. Then why you want to make the husband to prick the testis and take the sperm? So very careful. I don't know whether that person is female or male. So if it is a female, the husband is going to be suffer, because you are always you have to think about the easy way without pain, right? So don't do that. Revenge for whom? For the husband. Okay, fine, maybe. Okay, right. So the answer, question number 8, answer is C. Question number 9, a multiparous patient has cervical dilatation of 5 centimeter at 8 a.m., 7 centimeter at 12 noon. She's getting 4 contraction for 10 minutes. The station of the head is 2 centimeter above the ischial spine, moderate caput and gray to moldy. The membranes are absent. The sacrum is felt and the ischial spine prominent and incurved. The head, the fetal heart rate is 140 beats per minute. The most appropriate management. I'm really sorry. So I just want to explain. So that's why I was telling that story. Yeah. Okay. Yes. What is the answer? Right. So what is the diagnosis this one? Once you Maushika, what's the diagnosis this one? What is the diagnosis? Question number 9. What is the diagnosis?
Secondary arrest.
Secondary arrest. Okay. So the reason for that, primary arrest or secondary arrest, usually secondary arrest is different, but so the reason for this,
Cephalopelvic disproportion.
Cephalopelvic disproportion, right? So whatever the arrest is, it can't be a primary arrest because she's getting enough contraction. So the primary arrest is basically due to uterine contractile problem. So it's she's having enough contraction and labor started at 4 centimeter. Now it's 7 centimeter. It got arrest, right? And of course we can see the station it's still -2, very high. And when you do the vaginal examination, the pelvis, the sacrum is prominent and the ischial spine is incurved. So it means your pelvic outlet is smaller, mid cavity is smaller. So the pelvis is not adequate to allow the baby to come out, isn't it? And baby is trying to come out. That's why baby develop caput and molding. Still it's grade 2. Even if you wait for some time, it is going to be a grade 3 caput, but still baby can't come out because the space is not adequate. So in a rational way, if you think the labor got progress, labor got arrest, not progressing, so progression is slow, right? The pelvis is not adequate. Still baby is in higher station, not descending. So most of the features suggestive of cephalopelvic disproportion. So if it is a cephalopelvic disproportion, well, is it possible to have vaginal delivery? Is it possible to have vaginal delivery? No. Less likely to have vaginal delivery. So if you can't do vaginal delivery, is it worth to wait further? No. Because she is getting enough contraction, 4 contraction in 10 minutes. Irrespective of contraction, the labor is not progressing. Do you understand what I'm telling? So no point in waiting. Anyway, even if you wait, nothing will happen. So then you have to find the other way. Other way of delivery. What is the other way of delivery? Cesarean section. So the answer is going to be E. Right. Question number 10. Primipara is admitted to the labor room. Her cervix is 50% effaced and dilated to 2 centimeter. She is getting 2 uterine contraction per 10 minutes. Artificial rupture of membrane done and oxytocin infusion commenced. The progression of the labor is carefully observed. What is the best parameter of progression of labor? Answer 9. Question number 9, answer is E. Okay. So what is the answer for question number 10? Primary mother, 50% effaced, 2 centimeter dilated, ARM done, Syncho started, and they are monitoring the labor. How frequent you are going to do the vaginal examination? So we have studied in labor management. If we induce the labor, how frequent we are going to monitor the vaginal examination every 4 hours. If needed, we may have to monitor a bit early. but we are monitoring every 4 hours. Do you understand? We don't do frequent vaginal examination. The reason is why we don't do frequent.
Infection.
Yeah.
Infection.
Why? Because the risk of infection. So we don't do frequent vaginal examination. So minimum we have to do the vaginal examination every 4 hours. So the answer is dilatation of the cervix should be assessed 4 hourly. So 4 hourly or early, depend on the clinical scenario. So if you do the V in 4 hours, vaginal examination 8 centimeter. So when are you going to review? Vaginal examination 8 centimeter. When are you going to review? Next week.
In 2
Obini?
hours.
When are you going to review? So when you do the vaginal examination after 4 hours, vaginal examination is dilatation is 8 centimeter. So when are you going to review next? Yeah, that's true. It's in 2 hours. The reason is if it is 8 centimeter, we are expecting 1 centimeter per hour. So you are expecting it's going to be fully dilated in 2 hours. So you need to diagnose the second stage of labor. What is the reason you need to diagnose the second stage of labor? If it is prolonged, you need to do the instrumental delivery. You need to decide when to put the instrument. If it is fully dilated, if it is a primary in 2 hours, you need to put the instrument. If it is a multi in 1 hour, you need to put the instrument. So if you do V in 4 hours time, that might be already 2 hours gone in fully dilated. So then if you wait another 2 hours for the primaries, then altogether second stage is going to be 4 hours. That is not good for the baby. Do you understand what I'm telling, Charito? So that's why, depend on the V finding, you may have to decide when to do V, vaginal, repeat the vaginal examination. If it is less dilatation, 2 centimeter, 3 centimeter, 4 centimeter, 5 centimeter, then you can repeat in 4 hours. If it is 8 centimeter, 9 centimeter, 7 centimeter, depend on that, you need to plan your review time. Do you understand? Right? So even 2 centimeter now, after 3 hours, patient is telling, doctor, I feel to urge. I urge to push. What are you going to do? She is telling, I wanted to push. What is the meaning of that? What is the meaning of that? It's fully dilated. Second stage of labor. So it can be, you can't predict the woman and the labor. Even 3 hours, she might progress. So in that case, you need to exclude whether it's fully dilated or not. So then you may have to do the VE bit in 3 hours either. So if the labor is going in smooth way, your routine review is in 4 hours. Or if needed, bit early. If needed, bit early. Do you understand what I'm telling? Right. So the answer is going to be C. Question number 11. A primary para who attend your antenatal clinic wish to know the symptoms of onset of labor, which following the correct answer for the question. It's a straightforward theory question. So I'm always telling the symptom, the labor pain. What is the labor pain? Right. So usually colicky, bilateral, intermittent, increasing in intensity, increasing in duration, increasing in frequency, associated with show, with or without watery vaginal discharge. These are the features should be there for the labor pain. Right? Colicky, bilateral, intermittent, increasing in intensity, duration, and frequency, associated with show, with or without watery vaginal discharge. So what is the answer then? If you know the definition, that will be the only one answer. What is the answer then? It's going to be B, right? So colicky, low abdominal pain and backache with increasing in frequency, intensity, and duration with time. That is the definition. Straightforward question. Question number 12. A 25-year-old primary para whose antenatal period was uncomplicated is in active phase of first stage of labor. Vaginal examination reveal a cervical dilatation of 5 centimeter with absent membrane. The pelvis is adequate. The fetal heart rate is 135 beats per minute. A decision made to perform a cesarean section immediately. Which of the following finding is most likely cause for this decision? Sanjeevan? Go Sanjeevan. I miss Sanjeevan today. I can't see the
I'm
answer.
here, sir.
Yeah, what is the answer? Here, 12. B. Palpation of the anterior fontanelle layer and sagittal suture. Gael, you're correct, right? So the answer is D, right? Because you need to read the question carefully. 25-year-old primary mother, right? Antenatal period was uncomplicated. There is no problem in the antenatal period. She is in active phase of first stage of labor. Vaginal examination revealed 5 centimeter. Absent membrane. The pelvis is adequate, right? So the pelvis, the passenger is normal, passage is normal. So not passenger is normal, passage is normal. Active stage of labor, membrane got rupture, uncomplicated pregnancy. Fetal heart rate is 135 beats per minute. But still, somebody decided to do the cesarean section. So it means they thought there might be a emergency or there might be a chance of not having vaginal delivery. Here, obviously, there is no fetal distress. There is no CPD because, of course, because its pelvis is adequate, right? And no fetal distress, heartbeat is normal, but still they have decided to go for a vaginal delivery. Sorry, cesarean section. What could be the reason? So the approximation of the suture line. So approximation of the suture line is the grade 1 molding. That is the normal labor adaptation. For that, you don't need to do the cesarean section. Palpation of the anterior fontanelle and sagittal suture is a vertex presentation. Also, you can feel this one. So then for that, you don't need to do the cesarean section. Even if it is an occipital posterior, you can feel the anterior fontanelle and sagittal suture. For that, you don't need to do the cesarean section. Palpation of the eye, nose, mouth is a face presentation. Right? If it is a face presentation, right, then you need to assess whether it's mento anterior or mento posterior. Here they didn't mention anything about whether it's mento anterior or mento posterior. If it is a mento anterior, you can go for vaginal delivery. If it is a mento posterior, then there is no chance for the vaginal delivery. You may have to go for a cesarean section. So that is one of the indication for the immediate decision for cesarean section. Agreed? While they are doing the cesarean vaginal examination, if they found it's a mento posterior, then no point in waiting. They have to do the cesarean section. Right? But here they didn't mention anything whether it's mento anterior or mento posterior. So then we can't mark that, because if it is a mento anterior, we can go for a vaginal delivery. Right? Face presentation is not a contraindication for vaginal delivery. Mento posterior face presentation is a risk factor for, or is a contraindication for vaginal delivery. Agreed? Right. Palpation of the frontal bone and supraorbital ridge. Right? So what is it? It's a bro presentation. So with a bro presentation, can you have the vaginal delivery? It's not possible. Right? It's not possible. Then you may have to go for a cesarean section. So presence of caput is not an indication for cesarean section. So actually, in this question, among this answer, bro presentation is an indication for immediate cesarean section. But in clinical practice, if it is a bro presentation at 5 centimeter, what is your next step of management? Bro presentation at 5 centimeter, what is your next step of management? You can wait for another 2 hours or 4 hours. Why? Why? While the labor is progressing, either baby might flex or baby might extend. Both can occur. If the baby extends, what will be the presentation then? It's going to be face presentation. Face presentation you can deliver vaginally. Or if the baby is flexing, then again it might be a vertex presentation or sinciput presentation. Then they can deliver vaginally. So you have to wait for some time as it is 5 centimeters. If it is a fully dilated bro presentation, what is your management option?
C-section.
Immediate cesarean section. Because already fully dilated, you don't have time to wait. Nothing will happen after that. Then you may have to do cesarean section. Now you might understand how rationally you can answer. Depend on the situation. You can't say all the time, bro presentation, immediately I will do cesarean section. Still, you can wait for some time. I think we have done a question like this also. Bro presentation, what is the next step? Review in 2 hours. Yeah, that's possible. Do you understand? So you will get different questions. So don't memorize anything. Your question will reappear. The question what we are doing, definitely you will get this question in the exam, but there might be a small alteration. That's why I never promote the students to memorize the question. Don't do that. You memorize the concept. What we are teaching, just memorize the concept. So then you can pass. So I can prove even the proper, if I have a proper students who are obeying and who are practicing what I am teaching, I can do 100% pass rate. Right? So if you are obeying, so if you are not obeying, you are just hanging around here and there, then you can't pass. So then I am not taking the responsibility. Now I can take the responsibility for Sanjeevan, Charita, Kavinda, Pragaladan, Karan, Shivadevan, Maushika, because they are coming. So they are following the way of teaching. Yes. So if you fail, then I am the responsible person. I hope you are studying at home also, but I don't know. If you study properly and if you are practicing what I am teaching, so then I am the responsible person. Do you understand? But if you are not following, if you are just hanging around, so then I can't take the responsibility. Right, fine. So the question number 12 answer is D. Question number 13. A 25-year-old primipara whose period of amenorrhea is 39 weeks has blood pressure of 160 by 100. There is no albuminuria. The fetus is in cephalic presentation and head is engaged. The cervix is 25% effaced and os is closed. What is the next step of management? A. E. Perform cesarean section immediately. Gal is firing. Very good, Gal. Nowadays, I'm happy about you. You are answering very well. Now, right, okay. First, you understand this question, then we'll come to the answer, right? Most of the people are answering correctly, but you are wrong, right? So, 25-year-old primey, POA 39 weeks, blood pressure 160 by 100. So, the primey mother with hypertension, no albuminuria. So, what is the diagnosis? This is not the preeclampsia. This is the PIH, right? So, you can treat the PIH. It's not a big thing. So, if it is a PIH, what is the definitive management? Delivery. Because something is related to placenta, you just deliver the placenta. So, can you deliver this baby now? Is the baby matured enough to deliver now? Yeah, because the period of gestation is 39. So you can deliver the baby. So then you don't need to prolong the labor. Will you prolong the pregnancy? If it is 28 weeks, 30 weeks, yes, we need to prolong the pregnancy. Will you prolong the pregnancy here? No, we are not prolonging. So we need to deliver. So the definitive management is going to be delivery. Now, once you deliver, once you decide to deliver, now you have a question. Are you going to deliver? No, the time of delivery is going to be now. Now you can deliver. Okay. Now you have a second question. How we are going to deliver? Cesarean section or vaginal delivery? What is your answer? Cesarean section or vaginal delivery? for this patient, cesarean section or vaginal delivery? Will you do cesarean section for a simple PIH? No. The PIH, it's not an indication for the cesarean section. Until if the patient is having eclampsia, you may have to deliver cesarean section. Otherwise, you just give the antihypertensive for reduction of blood pressure and try to deliver vaginally. So you are aiming to deliver vaginally. Agree? Yes. So if you want to deliver vaginally, right, then you need to assess, is it possible to go for a vaginal delivery? So then you need to assess, how is the baby's size? What is the lie? What is the presentation? Whether the head is engaged or not. If everything is fine, head engaged, average size, longitudinal lie, so then the baby is suitable to go for a vaginal delivery. Then what is the next step you need to do? You need to check whether cervix is favorable to go for a vaginal delivery. Right? When you do the vaginal, now she's not in labor. So if the cervix is already dilated, then you can do the ARM and start syntocin. If the cervix is not favorable, if the cervix is not ripened, then what is your next step? You need to ripen the cervix. You need to open the cervix. Then you can make the uterus to contract. How can you make the uterus to contract? You can do ARM and start syntocin to make the uterus to contract. So how can you dilate the cervix? What is the way to dilate the cervix? What is the way to ripen the cervix? So how can you do the ARM with, so now we'll read the question. The fetus is in cephalic presentation and head is engaged. So are you happy now? Can you go for a vaginal delivery? Yes, we are happy. The cervix is 25% effaced and os is closed. Os closed. So how can you do the ARM, Sivadevan? You want to go inside the cervix and do ARM. Can you do that without opening the cervix? So can you do the ARM for this patient? What do you think? With a closed cervix? No. So what you want to do first before you do the ARM? Huh? You want to ripen the cervix. How can you ripen the cervix? With the prostaglandin. So there is no confusion if you properly read the question. So everything is in order. 39 weeks, PIH, need delivery now. So it's vaginal delivery is your target. Cervix is cephalic, engaged, but cervix is not favorable. Then you need to do some intervention to ripen the cervix. See how nice they are putting the question. If you understand, nothing to memorize. You can simply answer. So is there any drug induction which worsens the hypertension to the mother? No. So your prostaglandin will not worsen the hypertension to the mother. Right? Okay. But if you give the ergometrin, ergometrin is increasing the blood pressure. That's why we don't give the ergometrin for the PIH patient in postpartum hemorrhage management. So the answer is going to be insert vaginal prostaglandin is the answer. You can't wait for 40 weeks. So no need to read the other questions, other answers. If you properly read, there will be one answer. Nothing else. Agree? There are no answers, only one answer. Right, fine. So question number 14, a patient. So for 13, answer is B. Question number 14, a patient with mitral stenosis in first stage of labor, cervical dilatation is 4 centimeters. She is getting 2 contractions per 10 minutes. Which of the following most suitable method of analgesia? So it's a simple, straightforward question. So if it is a mitral stenosis, you need to have an adequate pain relief. No pain, no strain. That is your target in the heart disease patient. Why? Because if the patient feels pain, right? If the patient feels pain, which can increase the sympathetic activity and can cause heart failure. So you need to give an adequate pain relief. So what is the best pain relief in labor is going to be epidural. So there is no question on that. Epidural is the answer. Okay. Epidural is the answer. So answer is A for 14. Question number 15. A primiparous patient with diabetes is in labor. Right? Even the contraction is less. Okay. Doesn't matter. So will epidural affect the uterine contraction? Will epidural affect the uterine contraction? No. then what is your worries? She's in early stage of labor, you give the epidural analgesia. So then if you want, you can induce the labor. That is different issue. So here they are asking about the labor management. What is your labor management? Labor management is the epidural is the pain management option, right? A primiparous patient with diabetes in labor, her BMI is 30. Ultrasound scan measurement gave an estimated fetal weight of 4 kilo. The pelvis is adequate, the fetus is in cephalic presentation and direct occipital anterior position. The labor progress slowly. Which of the following complications are most likely to occur in second stage of labor? Epidural cause hypotension. That's why I told you, the epidural will cause hypotension with less incident when compared to spinal. That is one of the side effects, but it's less likely to cause hypotension in epidural. The epidural is the safest analgesia for a heart disease patient, right? Even if you are going to do the cesarean section, we are doing under epidural analgesia rather than the spinal anesthesia for heart disease patient. Okay, so question number 15. So what is the complication you are anticipating to this patient? So it's a nice scenario giving some risk factors for some complication, and they are asking what complication you can have. Sanjeevan, what is the complication you are anticipating? You can't mark wrong answer, then I will come to Baticalo and kill you. Yes? Read the question carefully. Primary mother has diabetes. So what are the problem? One, primary. Second one is diabetes. Her BMI is 30. Third problem is obesity. Ultrasound measurement gave estimated fetal weight is 4 kilo. Fourth one is macrosomia. Pelvis is adequate. So you can go for a vaginal delivery. It's not a big thing. You can go for a vaginal delivery. The fetus is cephalic presentation and occipital anterior. So the passenger is okay, passage is okay. Labor progress slowly. So it means the space is not adequate to allow the baby, but it's going on, right? Which of the following complications most likely occur? Diabetes, obesity, macrosomia. These are risk factor for
Shoulder dystocia.
nothing else. Shoulder dystocia, isn't it? So there is no question on that. Definitely you have to anticipate the shoulder dystocia. All the risk factors for shoulder dystocia is there. Obesity is a risk factor. Diabetes is a risk factor. Macrosomia is a risk factor. Slow progression is a risk factor. Prolonged first stage, prolonged second stage, instrumental delivery is a risk factor. Induction of labor is a risk factor. Do you understand? These are risk factors for shoulder dystocia. So if you read my notes in the book, there are 5 interpartum risk factors and 5 antenatal risk factors. Have you read that? Anybody? You go and read it today. There are 5 antenatal risk factors for shoulder dystocia, 5 interpartum risk factors for shoulder dystocia. It's in the book, right? So macrosomia, diabetes, obesity, right? Induction of labor, previous shoulder dystocia. Those are antenatal risk factors. Prolonged first stage of labor, prolonged second stage of labor, secondary arrest, right? So instrumental delivery, those are interpartum risk factors for the shoulder dystocia. All the risk factors they have mentioned here. So it's a risk factor for shoulder dystocia. So question number 5, the answer is D. Question number 16, primipara is admitted to the ward. The POA was 41 weeks, cervix is dilated to 3 centimeter, artificial rupture of membrane is performed. The LICO contain of moderate amount of meconium. Which one of the following best confirm the fetal distress? Answer please. Appu, before I read the question, answer are firing. This time SLMC is going to have a hard time. Yes. So I told you the ECG is the easiest way to assess the fetal distress, but the identification of acidosis. So if it is a fetal distress and hypoxia, which cause fetal acidosis. So the identification of acidosis by this ECG is less. Even if it is the abnormal CTG, 90% of the time, the baby is going to be normal. Do you understand what I'm telling? you might have a variable deceleration or late deceleration. You deliver the baby. When you assess the fetal acidotic condition, the fetal pH is normal. It means that your CTG is not that much sensitive to identify the acidosis. Agree? But still we are practicing because that is the easiest way to assess the acidotic status of the baby. Do you understand? Right? So that's why we are practicing that. But here, what is the best way is you can do the fetal blood sampling for the acidotic condition. So if the fetal blood sampling is less than 7.1, it's indicating the fetal acidosis. Actually less than 7.2 is indicating the fetal acidosis. Less than 7.2. The normal fetal pH is more than 7.25. If the pH is more than 7.25, it's normal. 7.24 to 21 is moderate. Less than 7.21, it's abnormal acidosis. If it is 7.1 means it's acidosis. So that is the most reliable one to assess the acidosis of the baby. Directly you are assessing the fetal acidotic condition. Do you understand? Only problem, you can do the fetal blood sampling after dilatation of 3 centimeter. Before 3 centimeter, you can't do fetal skull blood sampling. So here they have mentioned, now vaginal examination is 3 centimeter and membrane ruptured, meconium strain. So there might be a fetal distress. To confirm it, you have done the fetal blood sampling. The fetal blood sampling is less than 7.1. So it's indicating severe fetal distress and acidosis. Then you may have to deliver the baby by cesarean section. That is the most reliable method to assess the fetal acidosis. Do you understand? Right. So the answer is B. Question number 17. While delivering the baby, low outlet forceps, the initial direction of pull should be horizontal and downwards. So then only the baby's head will flex, and later then you have to pull upward. So it should be like that, J-shaped incision, right? So the answer is B. Question number 18. Primiparous patient has normal delivery in peripheral hospital. It's a nice question. 5 units syntocinon is given with the delivery of the anterior shoulder. Control contraction applied soon after the delivery, but the placenta is not delivered. What is the most appropriate management? Answer 17, answer is B. Okay, what is the answer for 18? Right, so Eurosha B. Await signs of placental separation. Right, so always you have to read the question carefully. Multiparous patient had a normal vaginal delivery in peripheral hospital. Peripheral hospital, that is the keyword in this question. Peripheral hospital. So the hospital like maybe a base hospital or divisional hospital. So there might be a one MO. Sanjeevan is the only one MO. There is no one is there. Right? No blood bank. There is no colleagues for Sanjeevan. Right? No theater. No obstetrician. No gynecologist. Right? No anesthetist. No ICU. So, but Sanjeevan reluctant to send the patient to hospital, tertiary care, and he delivered the baby, fine. After delivery, placenta is not coming. He did some intervention. He gave the syntocinon, he did the control contraction, the placenta is not delivered. So it's a retained placenta. So in that case, what is your management? You can try for a manual removal. The problem is, if the placenta is retained, what is the risk factor? What is the risk for that? There is a high risk of PPH. That is the first one. Second one, if you are trying to go for a manual removal, then there is a high risk of uterine perforation, PPH, infection, right? And uterine inversion. In case of PPH, do you have blood bank to give the blood? In sometime the retained placenta might be secondary to the morbidly adherent placenta. In that case, if it is a morbidly adherent placenta, you may have to do the hysterectomy immediately. So is it possible to do an intervention for this kind of patient in a peripheral hospital? So if it is an uncomplicated placental delivery, you just deliver the baby, deliver the placenta, and send her patient to the home. So if it is complicated, then that is the important thing as a medical officer in a peripheral hospital, when to intervene, when not to intervene, when to transfer the patient to the tertiary care center. Do you understand? So you need to know when to transfer. This patient should be transferred to a tertiary care center where the blood bank facility available, where the obstetrician and gynecologist, there, theater, anesthetist, ICU, everything should be there to do some intervention. In case of emergency, we may have to go for a laparotomy, hysterectomy, blood transfusion, ICU care, and all. Do you understand? So can you do some intervention for this kind of patient at peripheral hospital? So we are transferring the patient 33 weeks pre-eclampsia. We are transferring the patient from Mullaitivu to Jaffna. Why? Because we don't have the facility to look after the neonatal care. So then we can't deliver the baby. Do you understand? Like that. So we have to decide, depend on the facility, whether I can deliver the baby or I can't deliver the baby. So delivering the baby, doing cesarean section at 33 weeks is not a big thing. So Sanjeevan might be very good to do the manual removal. Yeah, I agree. You might be very skillful person. But is it safe to do manual removal for that patient in the peripheral hospital? That is the question. Do you understand? Always you have to keep a point in your mind. Do not harm the patient. Even if you are not doing the good thing to the patient, don't do bad thing to the patient. Do you understand? So you should know what you can do with your limitations. So the answer should be transfer the patient immediately to nearest specialist unit. Do you understand? That is the answer for the peripheral hospital. Okay, fine. Question number 19. A primipara complained of severe pain in the vagina 1 hour after the delivery. On examination, she is pale. Pulse rate is 120. Blood pressure is 90/60. Vaginal examination revealed large, soft bogey mass in the right lateral vaginal wall. What is the most appropriate management? So in question number 18, if the next step is asked, the next step should be the insertion of white bow cannula, right? Why? Because you are anticipating postpartum hemorrhage. That will be the best important next step as a peripheral person. So if the patient develop PPH while you are transferring, then peripheral vessels might collapse. Even the patient reach to the tertiary care center, they can't do anything. So immediately you have to put 2 white bow cannula, start IV fluid, and transfer the patient to the this one. So patient is already on syntocinon. So if the patient is on syntocinon, that doesn't mean the white bow cannula. So what is the cannula we are using usually for the labor management? This green color one, not the white bow one. We don't put white bow cannula, not 16. It's 18, green color one, right? So we don't put gray or maybe even white. We are putting the green cannula. So in case of PPH, or if you are anticipating the PPH only, we put white bow cannula. Why we don't put white bow cannula for all patients? Because white bow cannula insertion is very painful. Diameter is larger. So then we don't put the white bow cannula for uncomplicated patients. So the patient who are having high risk to develop PPH or patient already bleeding, then only we are putting the white bow cannula. Right, fine. So question number 19, a primipara. It's very good. Those questions should be asked from the students. So then those are the doubts. So if you have those kind of doubts only, yes, then you are thinking something, right? Okay, fine. So for the 18, you are asking, awaiting the signs of placental separation. So you need to keep one thing in your mind. Nowadays, in a universal practice, not to have passive third stage management. right? So waiting for the spontaneous separation is a passive third stage. It's not we don't do the passive third stage management, right? So you are going to wait for another 1 hour. If not, are you going to transfer? Or with the active management, if you can't deliver the placenta, will you transfer the patient to the tertiary care center? Which one is safest practice? What do you think? So you have to, as early as possible, if you feel the placenta is not separating, then better to transfer to the tertiary care. You have to be a safe house officer. You can't do like heroism work with the pregnant mothers. Do you understand? So one of the MO, right, who deliver a past section VBAC in a tertiary care center, especially in one of the island in Jaffna. So there are so many islands in Jaffna, like Delft, Analadivu, right? So Kites. There are so many islands in Jaffna, like around 10 to 15 islands. So each island has each hospital, right? Divisional hospital. One MO deliver a baby past section, trial of scar, in one of the island. It's not good to tell what is the island. Then what he did is he delivered the baby and he took the selfie with that baby and put it in the Facebook. So the successfully delivered be back in particular island, feeling happy, right? So then what has happened? Next week he called by the health ministry for an inquiry. Why did you deliver the VBAC in an island where there is no blood bank, no theatre? If the patient develop uterine rupture, right? How can you transfer the patient to teaching hospital Jaffna? First you need to be a safe doctor before you practice the things. You understand? So don't do the heroism work. More than that, if you do some heroism work, don't put it in the Facebook. That is going to be a problem to you. Do you understand? So actually what he thought is people will appreciate and congratulate him, and he can show the colors to others. But what has happened is he had an inquiry in ministry. So very careful when you are working. So if you work alone, right, so you can think. So that's why I'm thinking when I'm working in Mullaitivu nowadays, without MO, I'm thinking about the patient. I'm doing all the works I'm doing alone, right? So because I don't like to send all the patient to Jaffna. Once the patient comes with abdominal pain, if he send to the delivery to the Jaffna, those are very, very poor patients. So how can they go to Jaffna, the transport and things? We are thinking about that. So other way, another things are there. So while I'm having emergency cesarean section, the nurse is assisting the surgery because I don't have house officers or I don't have medical officers to assist. I'm doing the surgery with the nursing officer. So meantime, there might be some other emergency might come to the ward. In that case, while I'm doing the surgery, if patient died due to some complication because the nurse is not supposed to assist the surgery, the medical officer should assist the surgery. Or if mother got admitted to another emergency while I'm doing surgery without anyone, right? If it is a maternal death, no one will give any reward to me. So you are a great man. You have done a nice job with a single person. You did everything. Nothing will happen like that. So then the ministry will inquire me. So if you don't have a people, so how can you do a surgery with a nursing officer? How can you do a surgery with a nursing officer? Right? So you are not a safe person to practice as a consultant. You are a dangerous person. So then you have to be suspended from the work. That will be the reward we will get if we are working for the people. So always when you are working, you should know your limitation and you should know your safetyness as well. Do you understand? It's very important. What can you do? What can't you do? So I can do surgery, 15 surgery per day. Yes, I can. So in 24 hours, I delivered 30 deliveries in a on call, 60 normal vaginal delivery and 14 cesarean section. Within 24 hours, the maximum delivery, 30 delivery in an on call, in my own call. So I can't do work like that, but that is not so. That the safety is first. So I can't say I did 14 cesarean section within a 24 hours. I can deliver the baby. It's nothing. Yeah, it's nothing. But if something goes wrong, no one will help you. So you have to be very careful when you're practicing as a medical officer. Okay, Sanjeevan, right? So everything you need to know. So what are the things you can do? That's why the rational thinking is coming in obs-and gynae. You have to be a rational person. You can't be a theoretical person. Then you will be in trouble. If you try to memorize something, so just imagine. So passing the exam is nothing. Everyone can pass by memorizing. But after that, what are you going to do? That's a question. Now it's not like previous. Now everybody is filing the case, inquiry, a lot of things are happening. So very careful, right? Okay. So here, so what is the answer for the 19-1 is, what is the diagnosis? This is the perineal hematoma, right? Because severe vaginal pain, examination sees pale, tachycardia and hypotension. So it means class 3 hemorrhage, right? She had a vaginal examination with a large soft boggy mass. So it means something is bleeding and accumulate inside the vagina. So that is accumulating inside. That's why she's having bleeding. So what you have to do is you have to arrest the bleeding. Otherwise, what will happen? Continue to collect bleeding inside, and she will have shock and the patient will die. So what you have to do is, sometimes there might be a rupture inside and collecting inside the vagina. So you need to open the hematoma, identify the bleeding vessel and arrest the bleeding. Otherwise, continue to accumulate inside. Do you understand what I'm telling? So the diagnosis is hematoma, collection of blood into the vaginal tissue. Why? Some blood vessels has ruptured inside the vaginal tissue that is bleeding and it's collecting inside. So you need to open up, identify the vessels and ligate the vessels. Then only you can arrest the bleeding. Do you understand what I'm telling? Do you understand what I'm telling? Right. So the answer is drain and explore for the bleeding vessels. You have to explore and arrest the bleeding. That's the answer. Okay, so here administer analgesia and keep under observation. The question is, what is the most appropriate management? Administer analgesia and keep under observation. No point in keep under observation. Drain and explore the blood vessels. Yeah, that is appropriate management. Drain and insert figure of 8 switcher. Actually, the figure of 8 switcher is to approximate the surface. If somebody is bleeding from the surface, you can approximate the surface, then bleeding will arrest. Here, there is no bleeding from the surface. It's bleeding from the blood vessels. So you need to identify the blood vessel and switch the blood vessels, ruptured blood vessels, right? So that is not a possible. Insert vaginal pack. If something is collecting inside the vaginal tissue, what is the point of inserting the vaginal pack into the vaginal canal? No point. So then transfuse blood and keep under observation. Here, the transfusion of blood can be correct answer, but keep under observation can't be appropriate management. Do you understand? Because if you are keeping under observation, continuously patient will bleed inside and the hematoma will accumulate more. So that's why your answer is wrong, right? So if they don't mention keep under observation, the next step is going to be the blood transfusion, because already patient is hypotension and tachycardia, class 3 hemorrhage. What is the next step of management? Class 3 hemorrhage, what is the next step of management? Yes, what is the next step of management? If it is a class 3 hemorrhage, what is the next step of management? Blood transfusion. There is no question on that. First, you have to resuscitate the patient. Blood transfusion, stabilize, then only you have to go for appropriate definitive management. Do you understand? Then only you have to go for appropriate definitive management. Here, the blood transfusion and keep under observation, it's not a good option, because you can't keep under observation for hematoma. You have to do the corrective treatment as well. Right? Corrective treatment. You have to correct it. Okay, fine. So the answer is B. Question number 20. A 40-year-old primee attended to the antenatal clinic, period of amenorrhea of 10 weeks. She worried about the Down syndrome. Which one of the following most reliable to exclude the Down syndrome? So it means she came at 10 weeks worrying about the Down syndrome. Which one of the following is most reliable to exclude the Down syndrome? So here, So you have to tell about the diagnostic test. To exclude the Down syndrome, you have to tell about the diagnostic test. So the diagnostic test can be, so rest of the tests are screening, like your triple test, quadruple test, right? Or maybe cell-free DNA, whatever it is, all are screening tests. Two, reliable exclusion done by the diagnostic test. Once you do the diagnostic test, you can say no, 100% you don't have Downs. Do you understand? So the diagnostic test can be done with the chorionic villus sampling as well as amniosynthesis. Chorionic villus sampling and amniosynthesis. So chorionic villus sampling can be done at 10 weeks. Amniosynthesis can be done at 15 weeks. The advantage of doing chorionic villus sampling is you can do it in an early POA. The only problem when you do the chorionic villus sampling, right, the miscarriage risk is a bit high. Agree? Miscarriage risk is a bit high. And there are some few problems with the chorionic villus sampling. So have you heard the word placental mosaicism? Have you heard the word placental mosaicism? It means the placental tissue might have normal chromosomal cell as well as abnormal chromosomal cells. That is called mosaicism. So due to this placental mosaicism, you can have the wrong report as well, right? So, but your amniotic fluid will have the fetal cells, fetal tissues. So then that is more sensitive. So here they have answered which one of the following is most reliable. So you have to consider two things. Now she is 10 weeks. So if they ask what is the most reliable test to do as early as possible. So because she wanted to exclude the Down syndrome at 10 weeks, then even though your amniosynthesis is reliable, we can't do at 10 weeks. So then we may have to go for a chorionic villus sampling. Do you understand what I'm telling? But she doesn't worry about the time duration, whether she want to know whether at 10 weeks or 12 weeks. If she can wait until 15 weeks, then what will be the best option when compared to chordsynthesis? Amniosynthesis is going to be a most reliable one. Yes, she is elderly primary. Yeah, I agree. That doesn't matter. That is one of the risk factor for the Down syndrome. That doesn't mean you need to do at 10 weeks. If it is 40 years, are you going to do chorionic villus sampling for all? No. That's depend on the patient wish. Do you understand? So here they didn't mention anything about the time factor, when to do, when we have to intervene. So those things they didn't mention. That's why the answer is going to be D. So why I'm telling, I'm telling two concept here. So if they ask blindly what is the most reliable one, is the amniosynthesis. If they ask what is the best method to check the or exclude the Down syndrome now, what is the best method is going to be a chorionic villus sampling. Do you understand? Uvini? Yes? Yeah, okay. So any doubt? So we have complete this paper. So I will send the second paper, or the third paper. So the third paper class also going to be next Thursday. So then I will send the paper maybe Tuesday or Wednesday. So then please do the paper first before you come to the paper, because I'm going to do the paper very fast like this. So because this is the final preparation now, so then we have to do like that. But so don't come and get the answers. That is not useful. So first you have to do the paper, then come to the class. When you have the wrong answer only, then you will get to know why you are thinking in a wrong way. Then you can ask your questions, doubts, then you can clarify. Next time you will not do mistakes. Learn from mistakes. So answer for 20 is D. So they did, so in question number 18, they did traction soon after the delivered, but can wait some time, C. But if she deliver placenta after, she don't need to do anything. Is that so? Now here, if they mention wait until 30 minutes, yes. But here they have mentioned await signs of placental separation means, so waiting for the signs of placental separation is a passive stage, third stage management. So that's why we are refusing that answer. Otherwise, we can select surveyed signs of placental separation maximum for 30 minutes. Yeah, because that is the duration of. You are correct, Idosha. Because so once you reach the 30 minutes only, you can diagnose is a prolonged third stage, and you may have to transfer the patient. Here, they didn't mention anything. Yeah, that's why. Right.
So 18, then we can get the answer as a dean also, because we can wait another 30 minutes and he give the traction soon after the delivery.
Commence an oxytocin infusion and observe for half an hour. Multiparous patient has normal vaginal delivery in peripheral hospital. 5 units indocyanine is given with the delivery of anterior shoulder. Control contraction applied soon after the delivery, but placenta not delivered. What is the most appropriate? Yes. Yeah. We can take that answer D rather than transferring the patient immediately, because the question they have mentioned, the control contraction applied soon after the delivery, but placenta is not delivered. What is the most appropriate management? Because so immediately after the delivery, once you give control contraction, immediately placenta will not deliver. You're correct. So in that case, what you can do, you can wait for another 30 minutes. Once it is not delivered for 30 minutes only, then we may have to do the intervention. Until that, you can wait for 30 minutes. That is the normal duration of third stage of labor. Right? So if not delivered out after 30 minutes, then only we have to do the intervention like manual removal or something like that. If the patient is bleeding, here they didn't mention anything bleeding. If the patient is bleeding, will you wait for 30 minutes? No. In that case, you may have to do intervention a bit earlier. Right? So we'll change the answer for 18 as a D. The D is correct answer. Correct, Avinder. Right.
So SBA the 13.
Okay.
Yeah, it's mother is normal during the early pregnancy period. Then he developed the pregnancy-induced hypertension at 39 weeks. No.
Yes.
With that, before we are inserting vaginal prostaglandin, no need to check fetal distress or no?
Yes, we have done. But here the question, we are answering for this question. Of course, there are so many things we have to done before we insert the vaginal prostaglandin. One, we have to exclude the fetal distress. Right? Second thing, we need to do the investigation to exclude the preeclampsia, because even without proteinuria, still patient might have liver alteration and the investigation alteration. So we have to do the investigation. The third and important step, you need to control the blood pressure with 160 by 100. Right? If you wait for a long time, patient might have intracranial hemorrhage. So then you need to give the antihypertensive and control blood pressure. While you are doing, your definitive management is going to be delivery. Right? So then how you are going to deliver? It's going to be vaginal delivery. So here the question is regarding the delivery plan. What are we going to do? Are you going to keep the pregnancy? You are just monitoring, right? And cesarean section or maybe induction? That is a question. So you might confuse perform a bar physical profile. The bar physical profile, it's not a method of assessing the fetal distress. Do you understand? So the method of assessing the fetal distress is only CTG. Bar physical profile is a combined method to assess the fetal well-being. Right? So the bar physical profile has 5 components. What are those 5 components? One is fetal movement. Second one is respiratory movement. Third one is LICO. Fourth one is CTG and tone of the baby. Right? So those are the 5 components in the biophysical profile. So respiratory movement, breast body movement, tone, AFI, CTG. So your fetal movement and the CTG will reflect the acute hypoxic event. The LICO volume, tone, as well as the respiratory movement will reflect your chronic hypoxic event. So actually, your biophysical profile will give the fetal well-being of chronic as well as acute hypoxia. Why we are doing this biophysical profile? While you are prolonging the pregnancy, you need to check whether baby is doing good or bad. Do you understand? So if it is, for example, if it is IUGR, so if you want to prolong the pregnancy, you are just checking the baby's hypoxic status, chronic as well as acute hypoxic status. If fine, then you are prolonging the pregnancy for another 2 weeks and check the biophysical profile again. Here, will you do the biophysical profile here to check whether baby is good to prolong the pregnancy?
In according to this, fetal already in distress now. How we identify it? With
do CTG. If CTG
because
abnormality, cesarean section. That's it. You don't need to do the.
with the
You don't need to do the complete biophysical profile.
okay.
Just do the CTG only. That's it. If CTG is good, Doppler is good. That's fine. So the Doppler is not in the biophysical profile. Here we are doing the Doppler, right? And CTG. And if it is an abnormality, you deliver the baby immediately. That's it. Do you understand? So you don't need to do entire biophysical profile for this patient. Only CTG, that's it. To assess the fetal well-being. That's all. So biophysical profile is a complex process you have to do for 30 minutes and look for the fetal movement, look for the respiratory movement, look for the tone, right? So there are so many things we are assessing. So we don't need to assess all those things for this patient. We are just doing the CTG. That's it. If CTG is abnormality, do cesarean section. We don't insert the PG and we don't wait for that. So if the patient is already on, in question number 18, if the patient already on bleeding, most appropriate management resuscitation. Is that correct or transfer? Always, if the patient is bleeding, the first step, the next step is going to be the resuscitation. Before you transfer, you need to resuscitate. There is no question on that, no. First, you need to resuscitate, then you can transfer. Without resuscitation, don't transfer the patient, right? So can we please have a breech class audio recording? We had to leave the forensic class. I think I have shared the emergency audio recording, right? Yes, it's there. You can check in the emergency class group. The 4th class recording is available. You can check. To do ARM, is there a limit of effacement of cervix? Who is that person is asking? How to decide whether we can do the ARM or not? Yeah, Sanjeevan? How to decide?
So you want to know how to decide whether to do ARM or not?
Yes, how to decide whether we can do ARM and start Sindo, or you have to ripen the cervix. How to decide?
If the cervix is not ripened, you first ripen the...
No, I have taught this one. BISUP score, very good. BISUP score. We assess the BISUP score. If the BISUP score is more than 7, you can do ARM and start Sindo. If the BISUP score is less than 7, you have to go for a ripening with the prostaglandin. So we have discussed, I guess, right? So the BISUP score containing lot of factors, right? So dilatation, effacement, position, consistency, station, right? So this is a combination of your scoring system. Then only you can decide the BISUP score. So just check the emergency recording and let me know whether it's not accessible or not, because I have shared the recording, I think 2 days back. Just check and let me know whether it's not working or not. I thought it's working. It's working, right? Okay, fine. So please, the people who are having problem with the recording, so I think problem with your device. Okay. In chronic hypertension is a risk factor for PIH. Chronic hypertension is a risk factor for PIH. What man you are asking? So there are two types of hypertension. Either it could be a chronic hypertension or it might be a pregnancy-induced hypertension. If it is a chronic hypertension, it means already patient is hypertension. Then what you are asking about chronic PIH? PIH means already normotensive patient develop hypertension due to pregnancy. If it is a chronic hypertension, already hypertension. Yeah, that is chronic hypertension complicating pregnancy. That's it. Like your diabetes, chronic diabetes complicating pregnancy, or gestational diabetes complicating pregnancy. Like that, chronic hypertension complicating pregnancy, or pregnancy-induced hypertension complicating pregnancy. That's it. Yes, anything?
So question number 20.
Okay.
Since they have given 10 weeks and mother is worried, why should we wait for another 5 weeks?
Yeah, that's what we discussed earlier, no? So because the question is, what is the most reliable to exclude the things? They didn't mention anything about the time duration. So if the patient is requesting to get early results, then the photosynthesis is going to be the answer. Yes, they didn't mention anything about the time urgency or something. So they are just asking what is the most reliable method. That's why we select the.
Can't we take mother's worry as an urgency?
Yes, can, but the problem is when you are doing some intervention, always you have to balance with the complications as well, right? So as they mentioned, amniocentesis and chorionic pillar sampling at 10 weeks, of course, they didn't specifically mention about the urgency. So will you go for a high complicated procedure or less complicated and more reliable method? That's the question. Do you understand? So the purpose of identifying or diagnosing the Down syndrome in early POA is, if you diagnose at 10 weeks, the termination is going to be a less complicated method. But if you diagnose at 15 weeks, baby is fairly big, and once you terminate, the complication is going to be more, right? So that's why we are worrying about that. So that's why what we do is we are doing the screening test at first booking visit with a combined test. If the combined test is revealing as a high risk, then we do cell-free fetal DNA. If cell-free fetal DNA is positive, then you have to go for a chorionic pillar sampling, right? So if your screening test is still revealing as a low risk, right, even though it's 40 years, that's not a major risk factor. So what is the sensitivity of the age alone is 35%, right? So it's less. So for the less percentage, we are not going for an invasive procedure at beginning. So if the cell-free DNA is positive, then of course we are going for an invasive procedure. If not, then what we do is we are doing the second trimester screening with the quadruple test or triple test, and we are doing the hybrid test. What is hybrid test? We are combining the first trimester screening as well as second trimester screening and reassess the risk of Down syndrome in second trimester. If the risk is high, more than 1:150, then we do the cell-free DNA at second trimester. If cell-free DNA is positive, then you may have to go for amniocentesis. The aim of doing this screening test is to minimize the invasive procedures. Do you understand what I'm telling?
Yes.
So we are doing so this much of screening test we are doing to minimize the invasive procedure. So then because of the 40 years alone, we can't just tell I will go for a chorionic pillar sampling at 10 weeks. Do you understand? So
Yes.
Here they didn't mention much about the time factor. That's why. So with the less complication and most reliable, so then we can think about the amniocentesis for this question. So if they ask about the patient wanted to know in early or like that, so then we may have to think about the chorionic pillar sampling. Okay,
Okay.
right. Good. MCDA twin in labor, first twin delivered, second twin transfers like abdomen. Oh, internal podalic version with a breech exception. Both you can do. If first twin delivered, second twin is transverse line, then you can do the ECV and deliver the baby. If the membrane is intact, you can do the ECV and deliver the baby. If ECV fail, then you can do internal podalic version and deliver it. Emergency class 2 and class 3 recording say no permission. Yes, after 1 month, if you ask the permission, then so I gave the audio recording. So initially we promised to give the audio recording for 24 hours, but I gave for more than 1 week. Right now you are asking the permission after 1 month. So it's deleted. Then how can you get the permission now? Adenomyosis in the uterus size is usually less than 16 weeks of POA. Can it be more than 16 weeks? So usually it's less than 16 weeks, not more than that. But because it's the globular uterus, so usually it's less than 16 weeks, right?
Sir,
If the labor, can we do ECV? So thought answer internal podalic version. No. If it is in the labor, you can give top politics and do. That's why we are doing. We discussed those things, right? I guess. Is it, Charita? We have to give the terbutaline, tocolytic, short acting, fast action, do ECV and do ARM and start Sindo. That is how we studied. How gastrinone reduce the size of the fiber? That is because that is antiprogesterone. Yes, Chilanga.
sir, in question number 10, sir.
Huh?
In question number 10,
Your line is not clear. I couldn't hear you.
to assess the progress of the labor, sir. So why can't
To assess?
the progress of the labor, sir?
Okay.
Why does assessing cervix is higher than assessing the descent of the fetal?
Cervix is?
With the vaginal examination, can't we assess the? Isn't it better to assess the descent of the fetal head rather than assessing the
Cervical dilatation.
dilatations?
No, the cervical dilatation is the important factor to assess the your labor progression. That's why we are drawing the action line, alert line, and we are deciding for the cesarean section and things depend on the cervical dilatation. Do you understand? So there are two factors. We do like one is descent and the cervical dilatation. Okay. So I need to do this GTD. So will you be free tomorrow 9:30 p.m. or 10 p.m.? 10 to 11. 1 hour is enough for me. Do you have any class at 10 p.m.? No. Okay. So then we'll do the tropoplastic disease tomorrow 10 p.m. 10 to 11 or 11:30 we'll finish it off, right? Because okay, so then we'll do at 10 p.m. tomorrow, right? So I'll put it in the theory class group as well. So I'll send the link, right? So you can join to the class through that link. So tomorrow 10 p.m. we'll do the gestational tropoplastic disease. With that, our all pending work has been finished. So, okay. Why not Keelan Fisher's OP? Keelan has a lot of side effects. So Keelan is basically designed for the rotational forceps. 7 to 8 a.m. That is also possible. So what about the morning? 6:30 to 8. What time you are having class in the morning? But the only problem, students will have there's hospital appointments and things. So 6:30 to 7:45, will it be fine? Yes. because that is a good time you might understand. Otherwise, if you do it in the night time after 12 hours class, Russian students will be hard. Okay, so then we'll do at 10 o'clock. Okay, so the gestational trophoblastic disease class will be at 10 o'clock. Okay, 10 p.m. Okay, so we'll stop, right? Can endometriosis cause oligomenorrhea? No, it won't cause oligomenorrhea. Yes, exam technique. Most of the people went, okay, I'll give the recording. So the thing is, it's like that. Now you have a 1 month time for the exam, right? So now this is not the time to study your papers, your notes again and again, right? So this is the mistake my friends also did. I know that, right? So now you have studied a lot and you have all the classes, revision classes and things, I don't know. Now you need to have some time, sit and study, right? That is an important part. So what you have to do is, first, we have done so many papers, right? And of course, we studied a lot. Now this is not the time to study again your theory, right? So what you have to do is, first you take the paper, right? So that is the way I'm teaching to you as well. So what I'm doing, how I practice for my exam, I'm teaching the same techniques to you. So you will realize it when you go to the exam hall only. Until that, you will not realize, you will comment, and because you people doesn't have the experience about the exams, especially in Sri Lankan setup, right? And of course, you are talking about your seniors, opinion. So what they told you are thinking that will be the correct one. But I am the person did all the exams in Sri Lanka. I know the Sri Lankan exams techniques, and I know how to pass the exam in a short way. So what you have to do is, whether it's medicine, pediatric surgery, doesn't matter, right? So now you have some background knowledge, you studied something, right? So please keep one thing in your mind. Never ever, you can't memorize everything in your mind. That is not possible. If you think until you study everything clearly, I'm going to do the exam, you can't do exam soon. You can't do the exam soon, because that is not possible. Even you read the book for 10 times, 12 times, 13 times, you will not memorize the stuff. Okay, always you have to keep the stuff in a relative manner. So, right, so the brain has an ability to keeping the stuff inside the mind by comparing the stuff, right? So that is the normal physiology and psychology. You need to know those things, right? So when you are telling something, even you are just comparing the stuff and telling. So even sometimes, so when I'm asking, so Sivadevan, how is your girlfriend? Then he is telling, she's like Aishwarya Rai, she's like Asin, she's like Nayantara, right? So why is that? So you are comparing. So by comparing, you are keeping the stuff inside your brain. So it's same like that. So that's why when you study something in clinical practice, when you see the patient from the hospitals, you never ever forget the stuff. But sometimes you might study the same thing from the books, but you might forget easily. Do you understand what I'm telling? So the comparison will keep the stuff inside the brain. So that's why when I'm teaching, I'm telling some clinical scenario, some mistakes what we have done in the hospitals, right? So I have done this paper class in April. So that time I told the Kuchi Kuchi Rakamma stories, right? So even when I'm asking the theory part, the students couldn't remember the story, but when I'm telling something, immediately they are texting me. So endometrial thickness and IUCD, then some are texting Kuchi Kuchi Rakamma. Why? Because they are comparing the stuff inside the brain with the clinical scenario, right? So that is one, the comparison with the clinicals. Second one is repetition, right? So the repetition. So you might know, some people might have short-term memory loss following surgery, following accident, short-term memory loss. Even though they are having short-term memory loss, are they forgetting their own mother tongue language, the words, No. Why? Because of the repetition, it's going into the deep mind. Even if you have a memory loss, you will not forget the Tamil words, Sinhala words, English words. You can talk. But you can forget the event which has happened rarely in your life. Your love break. Once in your life. Right? So then you might forget because that is a rare event. I don't know whether it's really rare event for you, but if it is a rare event, so then you might forget. Do you understand? But some words we are telling continuously, then it will come spontaneously. Do you understand? So the second thing is the repetition. So the way of teaching, one technique is that my one. So I'm repeating. So risk factor for IgG, risk factor for PPH, risk factor for placenta previa. Whether you are studying at your own, whether you are sitting in front of the table, in front of the computer studying or not. So indirectly you are listening, indirectly you are thinking, indirectly you are memorizing yourself while in the class. So the people, especially the people who are from the November batch, just imagine how many times you heard about this exam fact. The risk factors, complications, diagnosis, management, next step, best step, everything. So now when you go to, until you go to exam, so this is our psychology. So before the exams days, now when you are preparing, when you are studying, you feel you don't know anything. Your brain is empty. Even after studying everything, you felt nothing inside the brain. So don't get stressed. It's like that. You studied a lot. Everything is in your mind. When you have the question, when you are in the exam hall, everything will come. So for that, what you want to do, you want to keep your mind very calm. So most of the people fail the exam because of the anxiety. Even they can't think in the exam hall, they are getting anxious, they are stressed. Don't be stressed. So the first thing what you want to do is, you want to be very strong when you have a stressful environment. Do you understand? So you need to know how to handle the stressful environment. So when I'm in the ward, if I have a severe PPH, if the patient is dying, everyone is running, everyone is struggling. But that moment, I used to be very calm. I don't scold anyone. Right? So I'm very calm. So even sometimes, even inside the mind, I might be a bit scared. Oh, patient is dying, I can't do anything. But so I try to be very calm. There are two reasons, two advantages. One, when I'm very calm only, I can think what to do next. Do you understand? I can observe the scenario, what is happening, why it's not responding, why she's bleeding like hell. What can I do next? Because that is, in that position, I am the only person who has to decide to save the person. If I am getting stressed, if I can't think what to do next, definitely that person is going to die. So I have to be very cool and calm during that moment. That is the first thing, right? But second thing, the people who are working under me, they believe, yes, the sir is there. He will do something. So when you are working as a junior, then you will realize it. When we have the emergencies, when the senior is with you, how you feel safety, right? So if the senior get anxious and senior is very tense, then your team will destroy. Your team will think, yeah, we can't do anything. So the entire the teamwork will destroy if you are anxious. You are going to be the leader. Do you understand? So tomorrow you are going to be the leader. So you have to develop your ability to be a good leader, good doctor. So the doctor is not a healer. You are a healer. You are a leader. You are a teacher, right? So you have to develop your attitude according to that. Your way of talking, your body language, your stress handling, decision making, handling your juniors, everything. Do you understand? So this is applicable for your studies as well. So if you are stressed, you might study. You are with the paper. You are reading. Nothing will go inside. So if you do 10 questions, doesn't matter. So if you are allocating the time for 1 hour for the general ops, you do 3 questions. Doesn't matter. Take your time. Just read it. Okay, miscarriage. So what is miscarriage? Recall, right? Imagine if you are lacking on that, just go backward to your theory and read something and write the additional points here repetition and repeat writing will keep the stuff in your mind. So when you are asking any question, I'm reflex manner, I'm telling to you, I'm teaching you. Why? What is the reason? Repetition. How long I'm teaching these things to your students? Whatever the chilly question you are asking, I'm answering. Why? Because I used to this. Do you understand? I'm not skipping a single question. The reason is I'm answering. Practice. Practice make perfect. So now this is the time. So what I used to do is I allocate the time. So today, so how many classes I'm having? So I'm having 3 classes, 12 hours. So then at least 2 hours I'm going to study. Half an hour for each subject. So just half an hour, doesn't matter. Recall it. One subject, you recall it. While you are recall, you just mark, okay, this subject I have to recall it. So next day when I'm starting again, what I used to do is, so if I recall the miscarriage today, right? The miscarriage part I have recalled. So tomorrow I'm going to do the ectopic pregnancy question. So before I do the ectopic pregnancy, just 1 minute to recall what I studied yesterday. Just 1 minute, nothing else. Just 1 minute. Go through quickly. Yes, these are the points. This is the type of miscarriage. These are the symptoms, signs, right? Manage. That's it. Just 1 minute or 2 minutes, not more than that. Quickly recall what you have studied yesterday and study today ectopic pregnancy. Then day after tomorrow, you recall the ectopic and study new topics. Now you can't study 1 topic per day, but you can study 3 or 4 topics and quickly recall it. So after 10 days, you complete all the parts, or maybe 1 or 2 papers. So if you see my paper, most of the papers, so I select to cover each and every topic. That is how I used to do the revision paper. So once you understand that, you will realize why I did the paper like this. So every paper has different topics. Each question has different topics. So once you do one question, that is one topic. Another paper is another topic. Another paper is another topic. So just imagine if you do 2-3 times indirectly, you are going to do 3 times, 4 times revision of your subject. So then when you go to the exam is not going to be a big thing for you, because this is an MCQ and SBA. So you can't predict what are the question will come. So, but obviously, you know, there will be a question in diabetes, hypertension, labor, right? Past section, IUGR, anemia, because these are the common things in Sri Lanka. Do you understand? So APLS, you might have question, might not have question. So in that case, if you have really limited time, you can skip the APLS, because if you miss 1 question, you will not fail. But you will get more questions on diabetes, hypertension, labor, anemia, past section, menorrhagia, fibroid, subfertility, contraception. So you have to concentrate more time on those topics. Do you understand what I'm telling? So then definitely, because you are supposed to get only 45 marks to get through the exam. Not much. So you have to target for 45. It means if you cover the major topics, you can get 80% of marks. Only 20% you will get in the minor topics like APLS, prenatal diagnosis. So I'm not telling don't study those things. You have to study those things. While you are doing the paper, you can just revise with the paper. But while you are doing the GDM part, diagnosis of GDM, so then you need to know there are 2 things: screening, diagnostic. What are the tests for screening? What are the tests for diagnosis? So if you go through in that way, you will realize that is the way I taught you, the concept base. If it is a diagnosis, you know what are the screening tests, what are the diagnostic tests, how to do the diagnostic tests, how to interpret it, how to manage later. That's it. Few points. If you know that, then you can do the paper. It's not a big thing for you. This is how I used to prepare the exam. So I never failed the exam up to now. Everything is first attempt, because but I don't do much time, much work like you. I'm doing all kind of extra works. Unnecessary work I can do. So because you don't, the first problem is most of the students are getting stressed. That is the major problem. Even some students are texting me now, sir, we are under stress. I couldn't concentrate. I'm going to stop the exam. Why? If you ran away from the exam because of the stress, when you are going to finish the exam? No, you have another 1 more month. It's more than enough. More than enough. You have good knowledge, you have good notes, you have good questions, good teachers. You can ask question anytime from the teachers. You can clarify your doubts, right? So only thing, you need to have a positive energy. That's it, nothing else. Right? I'm not telling I can pass. That is not the way. You can't say like that, I can pass. It's not a simple thing. It's a hard thing. But you should have a positive energy. Yes, I need to do. Do you understand? I can do. So for that, what I am going to do, how I am going to organize my time, right? So the positive energy, keep your positive energy around you, right? So throw your stress away. So if you are free from stress, then you will realize, yes, I can do. Yes, I can do. It's not a big thing for me. Right? So because you people are finish your theory, and what I felt is most of the students, mostly, you are having good knowledge. Only problem, you don't have that organization. Why can't you organize? You can. For the organization, how long you want? 1 month is more than enough. More than enough. The same thing is applicable for all subjects. It's not a big thing. So everybody can pass. Do you understand? Right? So don't worry. So you do. So now I am telling. So if you do my papers, those questions will come to your exam paper. But I will not encourage you. This question will come to the exam. Memorize it. That is not. Because if I try to do that, what will happen? You will try to memorize it. Don't do that. So memorizing will not pass. Will not help you to pass the exam. That's why still we are having less number of pass rate. Right? So this is my personal experience. Personal experience. So my personal exams experience, my personal teaching experience, right? So I'm always having high pass rate among my students, because students who are following my instructions, most of the, it's like that. So if I have 500 students, definitely 350 will follow me, 150 will hang around. That 350 will pass. That is my target, because those who are following, yes, I can. But hanging around people, they are not following and they are not concentrating, and they are just, because they don't know the real fact, but they will realize it once they fail. Right? So in my part 2 exam, we had the same example. So we have 4 people. One person is studying like hell. He can tell. So in evidence base chapter 3, page number 326, they have mentioned like this. If you go and see, it's there. Yeah, he's like that. So TOG 2016 October article, there is an article like this. They have mentioned now 26%. It's like that. He know the percentage either. He's studying like that. Right? So other people are studying like that. But I usually study for 3 hours, 4 hours. But what has happened? In part 2 exam, he failed the exam. He failed. I tried to make him understand, Anna, this is not the way to study. You know, but you don't know how to present, how to reproduce your knowledge in the exam. The studying is not the exam. Exam is a different art. That is depend on your reproducibility. So a lot of people has knowledge. Everyone can't reproduce their knowledge to others. So when I am teaching, I hope you people can understand, because I know how to reproduce my knowledge to you in a way you can understand. Do you understand? The same thing is applicable to your exam as well. He finally failed the exam. So among those four candidates, so other 3 also studying a lot, they are doing revision and all. So what I used to do is I used to go their discussion and I listen their things. Once when I am preparing my topics, I prepare very well and teach to them. So then when they are teaching, I'm just listening, I get their notes and just highlight something and prepare it. So finally in part 2 exam, among our group, my rank is far top. They are very, very bottom. One person is failed. So I'm not telling for the it's not the shareable thing. Why I'm telling is, so the exam is totally different. That is not depend on the time of studying. the amount of memorizing. It's not. You need to know what are the things you need to study, how to reproduce it in the exams. Do you understand? That is the important stuff. So everyone can easily pass. So next week after the KDU results, I will tell you what is the success rate of my KDU exam. Then you will realize which one is correct way to study, how to pass the exam in a small, simple way. So hopefully more than 90%, I guess, more than, but almost all pass probably, because if they are following, they can pass. That's it. You also same. So don't worry. First you study, try like this, right? Make a small notes. Don't think your time is going, doesn't matter. Make a small notes. So even when I'm teaching to you, this is used to me. I'm writing next to the stem always, right? Because even I know I used to write, because that is, I used to that. I'm writing when I'm reading the papers. Even after 1 year, when I'm doing the paper to other next batch, so if I see that, then I know what are the things I need to keep inside the mind. So everything will come in a flow manner. Do you understand? So try to do like this. If you have any clarification, any doubt, any help, anytime you can help me, you can ask me, right? Because so this is not the course basis teaching. This is the target to make you a good doctor to our country. So until your exam, anytime you can ask. So if you want, I can teach you, right? So that's why now I'm doing the free class, because if I'm not doing the class, then you will not study enough. You will concentrate the other subject, and with the exam tension, you will forget everything. So you need to keep this subject with this one. So in text. So then it's not a money matter. So always you have to study. So when you at least, so I know there are so many students from even though you are not coming to my class, you are attending to the free session. Yeah, now you are my students. So I need to take the responsibility to whom you are going, where you are going, whether you are coming to my class or not. Once you come to my class, then you are under my follow-up. So then I need to help you. I will help you. That's it. Okay. So study well. If you have any clarification, you can ask. So hopefully we need to have a higher pass rate. So I usually have more than 80%. This time I'm worried because I'm having a huge number of students. So I need to maintain the same percentage. So please try to cooperate and study. That's it. Okay. Okay, thanks you. So you go and study. So there is one more mixed incontinence. Should we treat the urge first? Yeah, if it is a mixed incontinence, first we have to treat the first urge incontinence first. Okay, good luck. Study well.